Hello, 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 hello. SSH गाँवकर yes D2 perfect चालू થઈ stream. Good afternoon to all. First of special thanks to my mentor Dr. Bansi Sabu sir, SR Arvind sir, Manoj Pava sir, and all Diabetes India team for giving me this wonderful opportunity in 12th World Congress of Diabetes India conference. Now I request to my co-chairperson Dr. Rajesh Desmani sir. He is a consultant diabetologist and metabolic physician at Sri Mahalakshmi Diabetes Institute. Over to you sir and introduce our first speaker of this session. Over to you. Introduce Dr. He is a senior consultant physician and diabetologist at Department of Physics and Metabolic Disorders, Mahavir Jaipura Raj. American Hello, American College of Endocrinology, Fellow of Indian College Madras Science Foundation, Diabetes India, Fellow of Glasgow and Edinburgh. So he has this awards and orations to his credits. He is also associate editor for International Journal of Diabetes in developing countries. Dr. Arvind Gupta sir.
Hello. Thank you, Rajesh. Thank you, Malay, for kind introduction. And at the outset, I also thank Dr. Bansi, my younger brother, Dr. S.R. Arvind, and whole team of Diabetes India to invite me for this wonderful Diabetes India conference at Goa. Dear friends, what I'll be speaking in next 15 minutes or so regarding just I want to emphasize in front of you that chronic kidney disease and the high CV risk, they are equal. I mean, they are the single disease spectrum, and if you would have there in the morning with Dr. Shashank Joshi's session, he also emphasized the similar things that CKD is equivalent to a cardiovascular risk, and not only CKD but also the diabetes also equivalent to the cardiovascular risk. Nothing special for this. Dear friends, these are the facts. The chronic, here we know that it was characterized by a progressive decline in glomerular filtration rate, years resulting in the permanent kidney failure. This was earlier we understood about the chronic kidney disease. But recent KDIGO, which the KDIGO statement, which states clearly the chronic kidney disease is defined as either kidney damage or reduced eGFR less than 60 ml per minute sustained for more than 3 months. This is the typical definition of chronic kidney disease. And what we know also about this chronic kidney disease, but it carries a large burden of comorbid, especially the cardiovascular conditions, than do without chronic kidney disease. And it has a actually additional burden of having congestive heart failure, myocardial infarction, and stroke. So dear friends, if you have a chronic kidney disease, you are having more risk for other comorbid conditions, especially the cardiovascular disease. So it is a vicious circle, and how the vicious circle is that we know that diabetic kidney disease develops in around 40% of patients with diabetes. This is the data, which is very recent data also. And type 2 diabetes, heart failure, and diabetic kidney disease are the major pandemics of this 21st century, and they often coexist. If you see here on the vicious circle, that type 2 diabetes leads to chronic kidney disease as well as the heart failure, and if you have all these phenomena, you have a sodium retention. So ultimately, if these conditions are not being treated or being prevented very early, then there will be permanent kidney damage, permanent sodium retention, and there are so many other complications. And if you see, there is a common thing. If you have a hypertension, if you have a reducing eGFR and proteinuria, ultimately what will happen? The cardiovascular morbidity and mortality will increase if you have all the three risk factors. We know this factor very well, that type 1 diabetes and type 2 diabetes, the chronic kidney disease is common. The diabetes is the real cause for approximately half of all the cases of end-stage kidney disease, and it amplifies. When you have a chronic kidney disease, it amplifies whatever the hidden or imminent cardiovascular risk is there, and it actually amplifies later. And patients with diabetic kidney disease actually ultimately leads to end-stage kidney disease. What are the data suggests to us that cardiovascular outcomes worsens with the chronic. As your chronic kidney disease progression occurs, your cardiovascular outcomes worsens. If you see here, whether the composite endpoints or death from cardiovascular causes or reinfarction, congestive heart failure, stroke, or resuscitation, you see here, as your eGFR goes and as your eGFR reduces, your cardiovascular outcomes actually increases. Similarly, your cardiovascular mortality risk also increases as your kidney disease progresses. Not only that, but risk of cardiovascular events is greatest when you have both diabetes as well as chronic kidney disease. And here it clearly predicted here that whether it is a congestive heart failure, acute myocardial infarction, stroke, peripheral vascular disease, atherosclerotic vascular disease, or even mortality, when you have diabetes and chronic kidney disease, it amplifies and increases more. So dear friends, mortality risk doubles when you have both type 2 diabetes and chronic kidney disease. And here, I think you have seen this in the morning with Dr. Shashank Joshi's deliberation. Cardiovascular disease in the patients with or without chronic disease, if you see here on the left side, if a patients with chronic kidney disease, and this is the very recent data, that you have cardiovascular congestive heart failure of around 43%, stroke around 26%, and acute myocardial infarction around 15%. But if you do not have chronic kidney disease, probably you have less stroke, around 20%, less congestive heart failure, around 18%, and acute myocardial infarction, around 6.4%. So both risk of MI and all-cause mortality in people with chronic kidney disease with diabetes, if you see the retrospective analysis, clearly it increases. And this is very typical of the eGFR relation with the cardiovascular events. If you see here, as your eGFR reduces, your increased chances of having more cardiovascular events. Similarly, cardiovascular mortality, if you see in the second, that as the eGFR goes down, your cardiovascular mortality increases. Similarly, the renal events are increased when you have a reduced eGFR. So what is the pathogenesis? How they are interrelated? There are several mechanisms, and scientists have evaluated several interrelated mechanisms why the cardiorenal symptoms are there. So if you see here, that it is the basically increased renin-angiotensin system, increased sympathetic nervous system, and reduced eGFR are one of the basic pathophysiology by which you have several other factors. If you combine with anemia, erythrocyte imbalance, electrolyte imbalance, mineral metabolism disorders, uremic toxins, malnutrition and inflammation, they all combine with this increased renal renin-angiotensin system and sympathetic nervous system, and that's why your kidney or renal effects are there. Similarly, in the arterial system, if you see here, there is a vascular resistance developed, left ventricular hypertrophy and left ventricular remodeling occurs, and ultimately it is an endothelial dysfunction leads to the decreased baroreceptor reflex, and hence your arteries are stiffened. So there are interrelated mechanisms. You have the traditional risk factors, like if you are older age, you are having cardiorenal symptoms. You have family history positive, hypertension, diabetes, dyslipidemia, or tobacco use, you are having more prone for cardiorenal symptoms. Similarly, there are certain newer factors like pressure overload, volume overload, RAS activation, or sympathetic activation, or even vitamin D deficiency can also have the more of the cardiorenal symptoms. And certain novel risk factors like endothelial dysfunctions, defects in glycocalyx, reduced bioavailability of nitric oxide, and these are the other inflammatory cytokines which may lead to the cardiorenal symptoms together. Not only this, the major acute cardiovascular events are more when you have a diabetic kidney disease. And this is the CAPTURE study, and this CAPTURE study clearly suggests to us that cardiovascular disease prevalence increases with age and reducing eGFR. If you see here, they are all shift to right. So there is a definite interaction between cardiovascular disease and chronic kidney disease. I'll not elaborate so many factors here, but there are interrelated several factors and mechanisms by which your arteries are involved, your heart is involved, and your kidneys are involved. So there is an interrelated mechanisms by which your diabetes and chronic kidney disease have common factors like hypertension, atherogenic dyslipidemia, endothelial dysfunctions, and they are, that lead to hypercoagulability and chronic inflammation and oxidative stress, by which your diabetes or hyperglycemia may lead to diabetic kidney disease. And this is a very typical example. If you see here, the coronary artery calcification in a normal coronary arteries, if you see the adventitia and intima, they are very much intact and clear-cut things are there. In a chronic kidney disease related to CAD, if what you see, coronary artery without atherosclerotic plaque, but later on, the heavily calcified atherosclerotic plaque you can see when you have a chronic kidney disease. And the extreme right side, non-chronic kidney disease, they also develop the calcified atherosclerotic plaque, but more when you have a chronic kidney disease. So there are several traditional and non-traditional risk factors. We have already seen that. And the prognosis is already there. According to the stage of KDIGO, there are different stages. And according to different stages, you have the cardiovascular risk more. And how to diagnose early detection of the chronic kidney disease in a cardiovascular disease patients. ECG is one of the most important thing. Earliest you do ECG and see if there are left ventricular hypertrophy. I think it is suggestive of the cardiovascular disease. Similarly, you can go for echocardiography. SPECT scans are there, dobutamine stress echocardiography is there, and you can go for even coronary CT angiography, by which you can diagnose very early the cardiovascular disease and how to prevent. That is the important thing why I am here. We know that cardiovascular disease and chronic kidney disease is a single disease spectrum. Hence, our more important duty towards the patient is to prevent as early as possible both chronic kidney disease as well as the cardiovascular disease. So it can be a primary CKD prevention. So you have to identify the risk factors. That is the most important. Identify risk factors earlier, which we have seen the traditional and non-traditional risk factors, and then do something to prevent the chronic kidney disease in a cardiovascular disease. In a secondary prevention, when you have already disease is there, then the detection of CKD very early in the cardiovascular disease patient, then do something. As Dr. Shashank told in the morning, I think everybody was there, that you'd either start with the Sglt2 inhibitors or mineralocorticoid receptor agonists. I mean, these are the drugs you have to start very early if you want to prevent the chronic kidney disease at the secondary prevention level. At the tertiary prevention, of course, there are several complications are already set in, like uremia and fluid overload, and you have to actually treat effectively as a tertiary prevention so that your kidney progression of chronic kidney disease may be slowed down. So how to manage? Statins are the drug of choice. If you have a dyslipidemia, that may reduce the atherosclerotic cardiovascular disease burden. Aspirin, if it is a secondary prevention, of course it is controversial at the primary level, but at the secondary level, I'll definitely start the aspirin. Other antiplatelet therapies are already available like GP2B3A inhibitors. They are already available, but safety is questionable. So, I mean, depending on the drugs, you have to think of this particular antiplatelet therapies. Some of the interventions are there, and if you have an interventionalist, then you can think of interventions in the management of chronic kidney disease, and of course, detection of clinically significant atherosclerotic cardiovascular disease and effectively manage the atherosclerotic cardiovascular disease. So dear friends, you have actually a dilemma and challenges in front of you when the patient comes to you as a cardiovascular disease and chronic kidney disease, whether it is a stage 1, stage 2, stage 3, and think of primary prevention, secondary prevention, or tertiary prevention according to stages of different chronic kidney disease as well as the cardiovascular disease. Think of cardiorenal interaction, do effective management as early as possible. There are several drugs, and I don't want to talk about the MRAs, Finrenon. The morning it was dealt in details, but little bit about the Sglt2 inhibitors. They are very good drugs, and I think whenever you have an early chronic kidney disease, start Sglt2 inhibitors as early as possible in your patients to either reducing the renal endpoints or the cardiovascular endpoints, MACE and congestive heart failure in your patients of chronic kidney disease with cardiovascular disease. This is a very recent one. I think this is not 1 month before. This paper has published in the American Journal of Kidney Disease, and this clearly suggests that if you can use very early Sglt2 inhibitors with metformin, not only several risk factors and several complications you can prevent, but also you can treat effectively the chronic kidney disease progression in a cardiovascular disease. Dear friends, so much has to be done in the future regarding epidemiology. We still do not know the exact data of chronic kidney disease in cardiovascular patients. Your presentation of these diseases is sometimes very asymptomatic, and you never actually realize that this patient has already set in chronic kidney disease in your patient. So early detection is the key. So presentation, don't go with the typical presentation that patient will come into typical uremia or renal failure. Of course, you have to predict, seeing the different risk factors, you have to predict and do certain tests to see whether patient is already having the chronic kidney disease. Of course, you have to understand, and in the future, we want to know more about the pathophysiology of different interactions, but still we know that oxidative stress, inflammatory cytokines, inflammation itself, fibrosis itself, that may lead to a cardiorenal symptoms. Thank you very much for patience listening.
Thank you so much, sir, for your very informative and excellent talk as usual. So now I invite our next speaker, Dr. Abhay Sahu, sir. He did MD Medicine and DM Endocrinology from AIMS. He is Professor of Endocrinology and Department of Endocrinology and
Metabolism
Metabolism.
IMS and Vaccine Hospital Bhubaneswar. He is organizing secretary of Acetone 2018, Acetone 2012 and Aerotone 2016. He is also co-organizing secretary of Acetone 2014 and 16. He is investigator in 3 ongoing international trials and recipient of the Rajasthani Gaurav Award Odisha in 2016 and Vikramra Sri Award in 2007. He is invited as guest faculty to various national and international conferences, and he has multiple publications, posters, paper presentations, and written many chapters in different books. So without wasting much time, over to you, sir.
Thank you, respected chairperson, my dear friends and colleagues. So, after Dr. Arvind Gupta's talk, totally probably it was such a separate thing what we are going to discuss. It is hypoglycemia associated autonomic failure. So, a lot of the time in our clinical practice, we know that once someone is diabetic, probably in the lifetime, someone has one or more episodes of hypoglycemia. And once there is hypoglycemia, how this hypoglycemia is responsible for autonomic failure and how it influences the management, we'll discuss that part. So once, if you'll discuss hypoglycemia, any episode of abnormally low blood glucose concentration that exposes the individual to potential harm. We know that any sort of significant hypoglycemia is one of the factor which plays a critical role. And how you are going to characterize hypoglycemia? Probably there is classical symptoms, either neurogenic or neuroglycopenic symptoms. And if you are measuring blood glucose, it should be measured in the laboratory. A blood glucose measurement by a glucometer is not advisable during the phase of hypoglycemia. And third most important thing is there occurs resolution of the symptoms of hypoglycemia after giving glucose. So these are the three things which is classically known as Whipple's triad. If we'll see different trials, we have actually from the morning we have seen a lot of discussions about different trials, how actually this, the standard control versus intensive control, the classical 3 landmark trials, if we'll see the ACCORD, ADVANCE and VDAT. The standard control group, if we'll see the hypoglycemia, it is quite less. But of course, we know, even if in our clinical practice, when you plan to do a tight glycemic control, always we face some sort of hypoglycemia, whether it might be a minor hypoglycemia, it might be sometimes, rarely it could be a major hypoglycemia, but the hypoglycemia incidence significantly increases. So you see the ACCORD, ADVANCE, VDAT, in the intensive arm, it is 5.1 versus 16.2, ADVANCE 1.5 versus 2.7, and VDAT 9.9 versus 21. So everywhere, a tight glycemic control has some sort of effect in hypoglycemia. And the important thing is, the majority time the hypoglycemia is unrecognized by the patient. If someone is having a mild hypoglycemia, many of the episodes are asymptomatic. If you are going a CGMS data, probably you can detect a lot about hypoglycemia. And in one study, you see in 63% of type 1 diabetes and close to 47% of type 2 diabetes patients have unrecognized hypoglycemia when you are measuring in the CGMS. So that shows that a significant number of mild hypoglycemia sometimes is not detectable. And the most important part is 74% of all those hypoglycemia does happen during the night. That is one of the biggest challenges, because we know during the night time when someone is sleeping, some sort of major hypoglycemia is quite detrimental and makes the patient might land up in complete unconsciousness or might land up in the hospital. So what are the, once there is hypoglycemia, what is the response of the body? What are the physiological response? The first response is decrease in insulin, which happens between a blood glucose of 80 to 85 milligram %. And this is considered as the first primary glucose regulatory mechanism, and that occurs, this is the first defense mechanism against hypoglycemia, that is decrease in the insulin. Rest second is increase in the glucagon, which happens between in the range of 65 to 70 milligram %, and that is the first counter-regulatory. It is not regulatory. Glucagon is a counter-regulatory hormone. It increases the blood glucose, whereas the decrease in insulin is the regulatory part for particularly blood glucose. So second defense mechanism is particularly reduction in the increase in the glucagon level. Third defense mechanism is epinephrine, but the epinephrine plays a critical role those who are having glucagon deficiency, that is utmost important. Those who are having glucagon is not there, probably epinephrine is the thing which plays a critical role. And the fourth is increase in the cortisol and growth hormone. They plays a role, but they are not critical. Second important part is that when there occurs blood glucose comes down up to 50 to 55, the first defense mechanism is the appetite significantly increases. Someone will have some significant appetite. If you are taking food at that time, probably that hypoglycemic episode will completely recover. But if still you are not taking anything, food, whether glucose, anything, then patient actually end up in decrease in cognition. Again, there occurs decrease in the brain glucose metabolism, which may leads to unconsciousness and seizure in the subsequent part. So these are the way how during the phase of glucose reduction, how the body behaves. This is the defense mechanism in the body. So what is the basic pathophysiology? If you see when there occurs decrease in the blood glucose, in the pancreas there occurs decrease in insulin and increase in the glucagon. And the liver, there occurs neoglucogenesis, increased glucose production. Same thing happens in the kidney, neoglucogenesis, increase in the glucose production, and they try to increase the blood glucose level. And what is happening to the brain level? From the brain, sympathetic outflow increases. That sympathetic outflow and from the acts on the pituitary gland, from the pituitary it stimulates the production of growth hormone and cortisol. And all those things increase in the epinephrine, and this growth hormone and cortisol, they try to increase the blood glucose level by specifically neoglucogenesis. And here, these are the some of the muscle and fat. There are some of the factors, the lactate, amino acid, and glycerol comes. This lactate, amino acid, and glycerol actually are the neoglucogenetic precursors, which is responsible for the production of the glucose in the body. Then this glucose in the CNS, when there occurs a glucose decrease in the glucose, this actually acts on the sympathoadrenal outflow is increased. This sympathoadrenal outflow, all those things acts on the liver, muscle, kidney, and fat. This leads to increased glucose production and decreased glucose clearance, and they try to conserve body or preserve glucose in the body, and this is the way how they defense or give some sort of defense against lowering blood glucose in the body. This is the important thing, that if you see this decrease in insulin, because in type 1 there is already they are insulin deficient. Again in type 1 that increase in glucagon is lost. So two defense mechanism, decrease in insulin, increase in glucagon is lost. Third is the increase in epinephrine is often attenuated. That is, there is increase, but that increase is not as required in hypoglycemic phase, and increase in the neurogenic symptoms that often is attenuated. So in type 1 patients, this counter-regulatory mechanism is defective, or that is not, does not work properly. So this is the reason we know a type 1 when there occurs the risk of hypoglycemia is significantly high, and the hypoglycemic on awareness is also significantly high in those group of patients. So what is happening in the different types? If you see take a non-diabetic patient, during hypoglycemia, the insulin decreases, glucagon increases, adrenaline increases. In type 1 diabetes, there is no increase in insulin, no increase in glucagon, and the epinephrine effect is attenuated. Early type 2, it is like similar non-diabetic, that is insulin decreases, glucagon increases, and epinephrine increases, but when it is late type 2, probably it behaves like a type 1. That means already there is all the beta cells is exhausted, so there will be no insulin production. The rise in glucagon will not be there, and again the epinephrine effect is be attenuated. So late a type 2 diabetic after 15-20 years, or a type 1 diabetic, they behaves like similar, particularly during the phase of hypoglycemia. So let us come to what is HAP, hypoglycemia associated autonomic failure. It's a reversible attenuation of sympathoadrenal symptoms of hypoglycemia. That is what we have discussed during hypoglycemia, the epinephrine increases. This increase in epinephrine is responsible for augmentation of the blood glucose and reduction of symptoms, but here it is not happening. So there is occurs a reversible attenuation of sympathoadrenal response to hypoglycemia due to recurrent hypoglycemia in the current past. There are two things happens. One is there occurs a defective glucose counter-regulation. That means this increase in insulin, increase in glucagon, decrease in insulin, increase in noradrenaline does not happen. Third is, second part is hypoglycemic on awareness. That means when there occurs a frequent hypoglycemia in the recent past, the patient reduces neuroglycogenic symptoms and neurogenic symptoms comes down. So this is leads to hypoglycemic on awareness, and this phenomena is result in a shift in the glycemic threshold. That means suppose in the normally we have discussed about the threshold that by 70 patient will start developing hypoglycemic symptoms. At around 60 to 65, glucagon increases, but if someone is having recurrent hypoglycemia, probably this threshold comes down, and unless until patient does not reach 30-40, probably these symptoms will not happen. So there occurs a gradual reduction in the threshold of the blood glucose to produce, because the body behaves as if a normal blood glucose 60-70, if there is recurrent hypoglycemia, body behaves as if the 60-70 is normal for the body. So there will be no reduction. So this hypoglycemic associated autonomic failure in early type 2 diabetes, that is relatively preserved. Insulin increases, during hypoglycemia, insulin increases, insulin decreases, glucagon increases, and adrenaline particularly increases. But in the advanced type 2 and type 1 diabetes, or relatively mildly moderate insulinopenia, that leads to actually no further increase in glucagon, or no further, there is no insulin reduction will be there, because already it is patient is insulinopenic. So due to this, actually this adrenomedullary epinephrine response comes down, sympathoneural response comes down. There occurs defective glucose counter regulation, also impaired awareness to hypoglycemia. That leads to actually recurrent hypoglycemia in those group of patients. So let us see what is the evidence is telling how the body behaves. If you will see, this is a study in the hyperinsulinic hypoglycemic clamp study, where actually if you want to see that before, suppose someone develops hypoglycemia, what is happening to next day. You see the glucose, it is almost same. Glucose is almost what the body behaves, glucose is coming down. You see the insulin again, in particularly during the phase of hypoglycemia and also normoglycemia, it is also similar. But you see the epinephrine level. After hyperglycemia, you see the right side, after hypoglycemia, the epinephrine is in the hyperglycemia, it is significantly high. But following after hypoglycemia, the white one, you see that is significantly reduced. So the epinephrine response is significantly reduced if someone develops recurrent hypoglycemia. The blood glucose is same, the insulin level is same, the glucagon level is same, but the epinephrine response comes down after even if a single episode of hypoglycemia. Again, if you see the total symptoms, neurogenic symptoms and neuroglycopenic symptoms, again you see the upper panel, the neurogenic and neuroglycopenic symptoms after hypoglycemia, again it is coming down or significantly less. So that means if someone develops recurrent hypoglycemia, the adrenaline or epinephrine response comes down, and there will be no adequate increase in the epinephrine. So this neurogenic and neuroglycopenic symptoms significantly comes down. So what are the risk factors for hypoglycemia associated autonomic failure? If you will see that is absolute endogenous insulin deficiency, if someone is having history of severe hypoglycemia or impaired hypoglycemic awareness or both, or a recent antecedent hypoglycemia or severe exercise or during sleep, or a aggressive glucose glycemic therapy to lower the HbA1c, to lower the glycemic goal. So these are the certain risk factors which can lead to hypoglycemia associated autonomic failure. So what are the mediators? These are the sleep, opioids, exercise, and serum cortisol. These are the some of the mediators which has been actually found to be associated with HAP. And this is the thing that they have compared. The A is actually during awakening phase, B is the during sleep phase. So what is happening to the particularly the epinephrine level during the awakening phase, you see there is significant rise, but during sleep the epinephrine is the B, you see the B graph which is significantly reduced. Sorry. So same thing, you see the what is happening to particularly the norepinephrine level, same thing happening. In the A, you see that during the awakening phase it is significantly high, but you see the B, that is actually it is significantly blunted. So during the sleep, the body response of release of epinephrine and norepinephrine also significantly less in comparison to the awakening phase. So this is one of the reasons why particularly during sleep the number of hypoglycemic events increases, or hypoglycemic associated autonomic failure is quite significantly associated with sleep. Again, the opioids, it has been found that during this, those who have having hypoglycemic associated autonomic failure, or during hypoglycemia, the opioid level is significantly increases in the body. So they try to give the opioid receptor antagonist naloxone, naltrexone. What is happening? They have seen that use of naloxone causes increase in the particularly sympathetic adrenal response to hypoglycemia, also prevents HAP. That means those who are having particularly HAP, probably one of the treatment modalities is naloxone, which can significantly reduce the HAP. Hence, it is one of the potential therapeutic function for particularly opioid receptor thing. Again, during exercise, usually opioid beta endorphin really significantly increases or significantly increases the sympathoadrenal response. So when a healthy individual do a vigorous exercise, this elevated endorphin reduces catecholamine release, or subsequently following exercise, the risk of hypoglycemia or response of hypoglycemia to particularly this adrenaline comes down. So following a vigorous exercise, if you are doing probably subsequently, the risk of response to hypoglycemia significantly comes down. So doing a vigorous exercise, we should be very much careful, particularly in type 1 and type 2 diabetic patients. Again, this hypoglycemia associated with elevation of the corticosteroid level is significant found, but again, CRH hormone plays a critical role for this impaired counter-regulatory part during hypoglycemia, but still, actually, they did not get an actual pathophysiology or actual way how this hypoglycemia is being counter-regulated by this cortisol is actually not well studied or well found in this mechanism. Then what are the mechanisms? The brain glucose metabolism hypothesis, brain glycogen supercomposition hypothesis, brain fuel hypothesis, and brain neuronal communication hypothesis. There are 4 hypotheses are there for particularly HAP. These are the, when there occurs hypoglycemia, first thing occurs, there occurs decrease in the energy depletion, also there occurs a metabolic stress. Due to this energy depletion and metabolic stress, 2 things will happen. Either there will be cell death, or cell will adapt itself to how the conserve energy. So if there is cell adoption occurs, there occurs alternate fuel, altered glucose metabolism, and also that ultimately leads to what happened in this decreased energy depletion and decreased metabolic stress. When there occurs a subsequent hypoglycemia, probably it can actually, this cell can sustain itself because by conserving energy. So this is adaptive or preconditioning by which actually cell death does not happen. But during this, if there occurs a energy depletion and decreased metabolic stress, that leads to decreased sympathetic activation, that leads to hypoglycemic unawareness and also decreased adrenomedullary response, and probably that plays a critical role for the HAP. So this is what we can tell, this is a maladaptive function of the body, or during this adoption to conserve or to preserve the cell, this is the HAP happens, or this hypoglycemia associated autonomic failure happens. So these are the certain particularly brain areas which actually acts this orbital prefrontal cortex, medial prefrontal cortex, they acts on the hypothalamus, and this hypothalamus, this decreased attenuated increased sympathetic activity, that is decreased insulin, no increase in glucagon, all those things actually acts on the pancreatic beta cells to actually plays a critical role for particularly the hypoglycemia associated autonomic failure. And what are the consequences if someone develops? Probably there occurs severe hypoglycemia, poor cardiovascular outcome, the cognitive and intellectual function comes down, there occurs dementia, there occurs psychological consequences, the quality of life comes down, and again, the economic burden significantly increases for the HAP. And this severe hypoglycemia, then hypoglycemic unawareness, we'll discuss about something that of course almost 40% in the type 1 diabetic patients, and we know that hypoglycemia unawareness increases the risk of severe hypoglycemia almost 17 times in type 1 diabetes and 6 times in type 2 diabetic patients. And those who are having impaired counter-regulatory hormone, they are further increase the risk of hypoglycemic unawareness in the range of up to 25 times. So you can imagine that this hypoglycemic unawareness is one of the significant factor which plays a critical role for defective glucose metabolism and defective glucagon response during phase of hypoglycemia. So again, there is a study which try to see during acute hypoglycemia, what is happening to the endothelial function. Here they have taken 2 things. The first one is the person having normal glucose. The second one is after next day, if patient develops hypoglycemia. And the third one is first day patient develop hypoglycemia, and the fourth one is second day again develop hypoglycemia. So 4 things. If someone is the left side of the panel, that is what is happening to the endogenous nitric oxide mediated vasodilation. In the day of euglycemia, it is normal. But as the patient starts developing hypoglycemia, you see there is a significant reduction in the nitric oxide mediated vasodilation. That leads to endothelial dysfunction. In the second part, you see that if you are giving exogenous nitric oxide, whether nitric oxide vasodilation causing vasodilation or not, you see in the normal person or euglycemic phase, it is normal. On the day of hypoglycemia, third one, it is almost similar with that, because on the day you might not get, but in the subsequent day, if developing hypoglycemia, probably it further significantly reduces vasodilation. So a first episode of hypoglycemia might not produce significant vasodilation, but if someone is having repeated hypoglycemia, that leads to significant increase in the risk of endothelial dysfunction, and that is one of the critical factors which leads to complications in the diabetes. Again, they try to see what is happening to baroreflex sensitivity. You see during hypoglycemia it is significantly coming, and norepinephrine and epinephrine level, again during hypoglycemia, recurrent hypoglycemia, it is significantly coming. And so when someone is planning a rigorous glycemic control, these are some of the things which does happen, or you have to critically think about these things during the rigorous blood glucose control. So this is a meta-analysis they try to see. It's from the International Hypoglycemia Study Group. They try to see during that severe versus no severe hypoglycemia, what is happening to the major cardiovascular events, major microvascular events, death from any cause, cardiovascular cause and non-cardiovascular cause, everything all actually prefers, yeah, 1 minute. So everything all is actually towards severe hypoglycemia in comparison to the second part. Again, the hypoglycemia associated autonomic failure, whether it is a maladaptive or adaptive function. So we see that if someone is having a maladaptive from the HAP, there are certain maladaptive response, like there occurs increased risk of hypoglycemia, arrhythmic death, and also atherosclerotic vascular disease. And once someone is having a recurrent HAP, probably subsequently a adoption does happen in the body, so arrhythmia-induced death is significantly reduced in those group of patients. So prevention and management is utmost important. You should acknowledge the problem, and aggressive glycemic therapy is not allowed. You should go for, particularly nowadays, we can have time in range profile we can make. From that, you can clearly do frequent SMBG, and CGMS use TIR, so that at least you can detect hypoglycemia and try to prevent hypoglycemia in those group of patients. And this is the individualized target. We know everybody, those who are having risk, those who are having microvascular complications, any sort of terminal ill, probably don't try to do or don't try to control the blood glucose tightly in those group of patients. And this is for type 1 and type 2. The target is always keep the hypoglycemic range in type 1 and type 2 of prolonged range. It should be less than 5% hypoglycemia. If someone is having a newly detected type 2, probably hypoglycemia should be up to 5% is allowed, more than that is not allowed. And treatment is optimizing the insulin. There are certain pharmacological therapy like beta-adrenals, like methylxanthine therapies, and other like islet transplants and fructose. Just another 1 minute. Fructose are there, so that you should optimize the OAD and insulin, like newer basal insulins, rapid-acting insulins, the risk of hypoglycemia will be less. And you should go for continuous insulin infusion. We have actually shown that if someone is having CSII, that actually significantly reduces the risk of hypoglycemia. Here in this study, actually from 1.25 to reduced to 0.05, the risk of hypoglycemia. So that is one of the important thing. Another important thing is islet cell transplant. That islet cell transplant, actually both it produces insulin and glucagon. Again, due to this glucagon response, the risk of hypoglycemia is significantly less. It has been actually pre-post, you say 87%, from 87% it has reduced to 13%. And some of the like beta agonists and methylxanthines are has been used for particularly to reduce the HAP or reduce the hypoglycemic risk, particularly asthma. So concluding my talk, the reversibly attenuated sympathoadrenal response to hypoglycemia due to recent or iatrogenic hypoglycemia is one of the important factors. Mostly occurs in type 1 diabetes, also in advanced type 2 diabetic patients. There are many experimental agents that can be tried and studied, but the goal is complete avoidance of hypoglycemia for 2 to 3 weeks. That can actually take care, or the risk of hypoglycemic unawareness will be significantly reduced with that much. Thank you.
thank you, Malak. And, thank you, Rajesh, for this kind word of introduction. And I appreciate Dr. Sharma. Thank you very much for this program. Thank you. And how are you? It's been a pleasure to have you. And thank you entire India team, including Bansi. I appreciate presence of Suprati, Amir, Abhay, and all of you. Those who have spent their afternoons, Saturday afternoons in Goa, you can imagine. And such a beautiful property all around, all around. It's very tough. But what I have done today is, I asked a favor from Dr. Sharma because I had a flight to catch back. And he was generous enough to allow me this session a little early.
Little off track. So Pratik was not very happy. He had some different plans for our session. But really, you can all ask difficult question to Supratik because he is all around here. And let's talk about the genuine question that has been always asked when we talk about the newer drugs available in the cardiovascular armamentarium that we have for, especially when the management of diabetes comes, is the cardiorenal panacea addressed with the latest drugs? So let's talk a bit about it. It's been amazing, isn't it, that how generous and how aggressive European Society of Cardiology was, and everybody appreciated their way of interpreting the whole management of diabetes and associated risk factors. And it was this in 2019 which actually caused a sensation in not only in the endocrine world, but in the cardiovascular people world, the cardiologist world, the nephrologist world, where they clearly came out and challenged the place of metformin as a first drug, even in the drug-naive patient. And they came out very clearly saying that when the patient is very high risk for an atherosclerotic cardiovascular disease, or the patient has got a high chances of developing a cardiovascular event or a renal event, in a drug-naive patient, you may consider either SGLTs or GLP-1 receptor agonists as the treatment of choice. And if the patient is on with metformin already, then there is no reason why you should be stopping the patients. And I'm going to talk to you about the same thing in continuation. A question which is asked usually, which is also now probably little bit addressed, not completely. American Diabetes Association 2022 still is little conservative as far as the choice of the therapy at the initiation is concerned. They still want to stick to metformin. But then what is most important is that they have now clearly come out again with the same echoing of the the European Society of Cardiology guidelines, saying that if the patient has got a high risk for an atherosclerotic cardiovascular disease or a heart failure or a kidney injury, initiate these patients with either the SGLT or the GLP-1 receptor agonist. So the question is renal cardiometabolic disorder is a panacea available now? Friends, I am Dr. Mangesh Tivaskar. We all know that heart and kidneys, as Arvind has beautifully alluded to it, they are absolutely hand in glove. Something goes wrong to the heart, kidneys are going to shout out. Kidneys are unhappy, there is going to be a challenge. And majority of the times you all must have witnessed that, especially in the patients, those who are on with the hemodialysis or a renal replacement therapy at the end stage renal disease, majority of the patient, nearly 50% crowd, they do not even reach the stage of dialysis, they develop a cardiovascular event and we lose them. So that is the intent, and the connect is very intense. And the organ dysfunction, no matter it can be the systemic effects or the sympathetic effects or the inflammation or the endothelial dysfunction or the oxidative stress or excessive fibrosis, but these two concomitant disorders are the highest reasons for the mortality associated with diabetes and the metabolic challenges, and we all are aware about it. And we all love evidence-based, right? We all of us love evidence-based. And we always talked about the importance of statins, BP lowering medications, especially beta blockers, metformin, ARBs, ASS. But then in last 5 years or so, we are blessed with these two agents, GLP-1 receptor agonists and Sglt2 inhibitors, to manage the cardiorenal risk continuum, which is the cause of concern. So let's first look at Sglt2 inhibitors, and we all are 100% convinced about their efficacy, their ability. If you really put in all the Sglt landmark trials together, no matter it could be all-cause mortality, a cardiovascular death, a 3-point MACE, or a renal continuum, you will see that SGLTs did a magnificent job. It was for the first time any trial in the cardiovascular basket has proved the superiority as far as the outcomes are concerned. And we were very happy. Not only we were happy, we were stunned, we were mesmerized. We were not very sure what is happening. And what is most wonderful thing about these drugs was that the benefits were very, very quick. As quick as 15 days, DAPA heart failure showed 15 days benefit. So the Kaplan-Meier starts separating technically between 10 to 15 days. Tell me which drug does that? Now that is the place where SGLTs have scored probably over the other group of the drugs. And surprisingly, if you really look at the other glucose lowering therapies, they did not, even though they had a great glucose lowering ability, but they never had this superiority benefits or the outcome driven, I would say, benefits. And these are all the explanations which are given by most of the world. But I'm going to tell you about some newer nuances of SGLTs. Now this is what the SGLTs are doing differently apart from the regular effects that they are thought about. No matter, it could be the effect on the renal hypoxia by addressing the sodium hydrogen exchanger forms, NHE3 forms, where it reduces down the renal hypoxia. It can be adipokines and the reduction in the inflammation. It could be the epicardial fat. It could be the different way of handling the ketogenesis and the small ketone energy fuel mechanisms. So myocardial energetics is different. The lipid handling is different. Inflammation is different. Reduction in the volume is different. And this has been proved by, this is a beautiful paper by Subodh Verma and team. And this got published in 2018, and we know how different SGLTs are when it comes to the volume loss. They cause volume loss in the right places. And what is the beauty of SGLTs is this, that they do cause the fall in the intravascular volume by reducing down the interstitial fluid congestion, which is the most difficult fluid to treat. A small data from the empagliflozin group, but I am sure that dapagliflozin and to a certain extent Cana also has, that the fluid loss happens, but it is free of electrolytes. So you don't have to be worried about the electrolyte challenges. This is most important. I don't feel so any other group of the drugs have shown this. Look at the pulmonary end diastolic pressure. 2 millimeters drop in the pulmonary end diastolic pressure, and that is the reason why, probably one of the reasons why patients, they are benefited even with the heart failure with the preserved ejection fraction or a mid-range ejection fraction, because this is what is happening. Fuel energetics, I am not going to go into the details about it. Probably Dr. Sundar Mudliar, Subodh Verma beautifully published this paper in various cardiology and the diabetology journals. But they do what? They improve on the glycogen related challenges, the free fatty acid related challenges. Not only that, the fatty acid oxidation goes down. The beautiful thing is this, that glucose oxidation, so glucose starts getting utilized beautifully well, and that is the way it impacts the cardiac fuel energy handling. One of the very interesting data which has again come from the SGLT2 group is this, that not only they do cause the systolic and diastolic blood pressure drop, but also they cause drop in the central aortic pressure, which talks about the improvement in the vascular health, which talks about how it is important to manage arterial stiffness, which is the main culprit. And that is the place where probably empagliflozin, even though this is an empagliflozin driven data, but probably, dapagliflozin also has got a similar data there. Same way, EMPA hemodynamics had shown that in a patient, those who are with preserved ejection fraction, there is a reduction in the end, left ventricular end systolic filling volume. So that's how probably in the preserved ejection fraction, the patients are benefited. It changes the entire left ventricular modeling. So left ventricular hypertrophy goes down, the oxidative stress goes down, and not only that, it also causes reduction in the fibrosis markers. Now what are the fibrosis markers that you are looking at? Fibrinolactin, or the smooth muscle proliferating factor. These are all the things which actually are the pre-fibrotic markers, and you can clearly see that the patients on with empagliflozin or dapagliflozin, they beautifully get benefited. SGLTs reduce inflammation, no matter it could be a TNF alpha, an interleukin 6, and you are talking about CRP. Not only that, the adiponectin levels, they go up, leptin levels go down, and the ratio of leptin and adiponectin, which actually talks about the cardiovascular health, it improves a lot. This is what I have already spoken about, the renal stress-related hypoxia. So whenever there is an SGLT is on board, the sympathetic nervous, and this is what exactly Dr. Abhay Sahu was talking about, that whenever you are having either hypoglycemia or the related challenges or a cardiovascular challenge, one area which is of a concern is usually the sympathetic nervous system. Now you have a drug which can reduce down the sympathetic tone, and that's how where probably by acting on the sodium hydrogen exchanger form, SGLTs reduce down the arterial stiffness at the kidneys. It reduces down the sympathetic stimulation and will reduce down the incidence of heart failure. So it doesn't just act on the heart, but also beautifully acts on the kidneys. As far as the renal benefits and the arrhythmia benefits are concerned, I'm not going to touch upon this. So these are all the new areas where SGLTs are now also credited for benefiting as far as the cardiovascular outcomes are concerned or the improved cardiovascular outcomes are concerned, where you are talking about the altered adipokine regulation, you are talking about autophagy, you are talking about the organelle clearance, you are talking about reduction in the oxidative stress, you are talking about the improved cardiovascular ionic homeostasis, and also you are talking about the better handling of the myocardial energetics. Amazing ways of renal benefits. So whenever I talk about SGLTs, I really am mesmerized that how much and how many things these drugs are going to uncover to tell us that yes, these drugs, they deserve a genuine attention. Similarly, if you look at the GLP-1 receptor agonist, almost similar, not as potent as SGLTs as far as these benefits or the evidence base is concerned, but then there are some signals. Look at LEADER, look at SUSTAIN 6, look at the outcome trials, the hazard ratios, the benefits of 3-point MACE, cardiovascular death, non-fatal MI, non-fatal stroke going down significantly. LEADER proved that primary MACE outcomes go down significantly. The cardiovascular death, every 1 in 5 patients are benefited. Apart from that, just not weight loss, but the kidney protection along with the reduced inflammation is a part. If you really look at the SEMA data, now SEMA is now a heartthrob of a lot of people, and especially after oral semaglutide launch. But look at SUSTAIN 6 or PIONEER 6, 24% relative risk reduction. That is significant. Now 24% may not hit you here, but what if I say that every 1 in 5 or 4 patients are benefited? Do you realize the value of these drugs? Liraglutide has beautifully showed that it can have an ability to stop the progression of atherosclerosis. So whenever the patients, they have a progressive atherosclerosis or an established atherosclerotic cardiovascular disease, these are the patients who are likely to be benefited as SGLTs. Along with that, probably GLP-1 receptor agonists in combination are going to really mesmerize all of us. LEADER also showed that the cardiovascular outcomes, they are significantly better in the liraglutide arm, and the renal benefits are also equally significant as the cardiovascular benefits are concerned. LEADER again showed that the primary cardiovascular outcome in the patients of an established chronic kidney disease are also significant and worth taking note of. It reduces down the progression of macroalbuminuria, need for the renal replacement therapy, or the need for the renal transplant. It is amazing, and this is uniform in almost all the SGLT related trials. So finally, friends, if I have to talk about the continuum of the cardiovascular renal panacea, at one arm you have got SGLTs, on the other arm you have got GLP-1 receptor agonist. SGLTs, vascular euphoria, and the GLP-1 receptor agonists are the anti-atherosclerotic, anti-inflammatory effects. Now these two combined will offer you a complete coverage of the cardiovascular renal axis. That is a challenge. So that is exciting perspective for diabetologists, for the primary care people, for the cardiologist, and for the nephrologist. And you will find that these are the only molecules where the cardiologist, endocrinologist, diabetologist, nephrologist, physicians and even the primary care people sing the same song of appreciation for these two molecules. So finally, friends, how true it is and how important for us to understand. It is our job as clinicians, as doctors, to give them medications to our patients that they should function to stop people dying young. So the people must die young as late as possible. This was a beautiful statement by Ernest Widner. How early? Maybe right at the inception, because if you wait for an event and to start, then probably you are not practicing the evidence-based medicine now. And especially whenever you look at the SGLT trials, especially look at the Declaratimi, where they talked about primary prevention so beautifully well. So the question of, is cardiorenal metabolic disorder, is panacea achieved now? I would say that this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. Thank you very much for your kind attention. I
Thank
really
you,
appreciate
thank you.
And thank you, Dr. Sharma sir, again for my so much being kind to me. Thank you very much.
Thank you so much, sir, for wonderful and excellent talk as usual. So now I requesting to, if any question, all of the three speakers are here. Please, any question. So, special thanks to
Divakar sir, Professor and Arvind sir for wonderful and excellent talk as usual. And it's our pleasure and honor to listen you, sir. Special thanks to all of you. And special thanks to Rajesh sir for chairing the session. Now I request Dr. Viral sir for chairing the next session. Please come on. So good evening, friends. We move on to the next session. And though this session was dedicated to the cardiorenal metabolic continuum, and the excellent work given by Dr. Arun Gupta and Dr. Foster sir would go a long way for this session. But before that, we will basically deliberate on the errors made in the management of the diabetes. And for this, I am inviting Dr. J.K. Sharma sir for his deliberation. He is the medical director, Central Diabetes Center, New Delhi, visiting professor and faculty Department of Medicine and Pathology, Diurnal Medical College, COD Academy of Higher Education Research, Belgavi, Karnataka. Honorary Professor, IIM Headquarters, Perfect BSc by OpenView Medical Education University, Uttarakhand, MRCP UK, Thesis Examiner, International Advisor, Royal College of Physicians of Edinburgh for North and Central India, Fellow American College of Endocrinology, Fellow all 4 Royal Colleges of Physicians, Vice President American College of Physicians, ACP India Chapter, Chairman Elect RSSBI Delhi Chapter, Founder and Secretary General, Innovative Physicians Forum, Vice President Genetic Society of India, AC Member RSSBI National, and recipient of Lifetime Achievement Award 2018 from RSSBI Rajasthan Company. So with these words, I invite Dr. J.K. Sharma sir for his deliberation.
Good evening to all. Thank you, chairpersons, for the kind introduction.
heartfelt thanks to the people sitting over here because as Dr. Mangesh said, Sunday afternoon, Sunday evening, even good number of people are sitting here. And thanks to Dr. Bansi Sabu, Dr. Manoj Chawla, Dr. S.R. Arvind and all the team of Diabetes India Organizing Committee. Dear friends, I will not be talking about the recent advances and all these super special talks by the stalwarts in the field of endocrinology and diabetes. But I will talk to you regarding something which is of use to we all, starting from the general practitioner up to the top end endocrinologist. And there are certain things which we must always look for, because it is always said, if you cannot do good to the patient, please do not harm the patient. So my talk is common clinical errors in diabetes management. We all know that management of diabetes is a state of art. And first of all, the diagnosis should be confidently acknowledged. Clinical examination should be perfect. The choice of therapy is tailor-made. We have to decide which patient needs what, and always look for the associated comorbidities, and they should be effectively treated. Otherwise, if you look at the fallouts from diabetes, toes are shaved off, the kidneys fail, the nerves, the heart, the brain, they all wreak havoc on our body, and then the life becomes the grueling struggle. And we all know that diabetes management is not a sprint. It is a marathon. We have to keep running. We must not be too stringent in our management application right from the beginning, as it runs the risk of the patient being burnt out and not following through on their treatment in the long term. So if we want that this patient should have a HbA1c in the normal range, below 5.7, never ask for that. What we should look for that, the HbA1c, if we can keep between 6.5 and 7 in a general population, that will be good. And in elderly also, the range is different. This is regarding the diagnosis of diabetes, and we all know that the ADA's diagnostic criteria, A1C 6.5 or more, and this test should be performed in a laboratory using a method that is NGSP certified and standardized to the DCCT assay. Or fasting more than 126, fasting is defined as no calorie intake for at least 8 hours. 2 hours plasma glucose more than 200 during an OGTT, and in a patient with classic symptoms of hyperglycemia or hyperglycemia crisis, even a random blood glucose level of more than 200 milligram is sufficient in making the diagnosis. There are dubious values. Fasting plasma glucose of 115 or random plasma glucose of 200 or fasting plasma glucose of 130 milligram and random of 180. Now they are non-diagnostic. And then in that case, we have to repeat the sample on the subsequent day. And especially look for the hyperglycemia during the acute stresses like the acute MI. And then again, we have to look for, revise the diagnosis once the stress is over. We should not label the patient diabetic until the stress is over. And again, we look for the, what are the test results. In mild diabetes, severe diabetes, these are not the terms which should not be used by a clinician, because there are the layman terms and they are very, very dubious terms. Now, the advantages for the fasting plasma glucose assay is easily automated. It is widely available and it is inexpensive and it is single simple method. The disadvantages are the patient must be fasting for 8 hours, and there is a large biological variability. Diurnal variations, sample not stable. Some labs use serum instead of plasma. So all these factors should be considered before deciding. The oral glucose tolerance test, again, it is a sensitive indicator of risk of developing diabetes, early marker of impaired glucose homeostasis, and at this time,
we can pick up the pre-diabetic patients or look after them, lacks reproducibility, extensive patient preparation is required, time consuming and inconvenient for patients, unpalatable, expensive also, and it is influenced by various medications, sample not stable to be done in the morning. Now HbA1c, at the time when we were in the medical schools, the test or the parameters, the factors which we were taking care of was the urine sugar, the urine ketones, blood sugar fasting, 2 hours postprandial blood sugar, or OGTT. But now is the time when we go for HbA1c, when we go for glycemic variability, and now again is the time when we look for the time in range. So with time things are getting changed. HbA1c, no fasting is required, sample may be taken any time of the day, very little biological variability, it reflects long-term blood glucose concentration, assay standardized across instruments, and concentration predicts microvascular complications. Disadvantages are may be affected by decreased lifespan of the RBC in different conditions. Selected hemoglobinopathies may interfere and may not be available at all places, and it is costly compared to blood sugar fasting. Now the factors that affect the A1C, there is a decreased HbA1c value in pregnancy by 0.5%. Vitamin A and vitamin C consumption also decreases HbA1c. Antiretroviral drugs, chronic liver disease, ethnicity like in Asians, and hemoglobin S, D, G, C, and E, so they all have a decreased value of HbA1c. On the other side, it is increasing with age, 0.4%. When there is high triglyceride or high bilirubin, again it is increased. Renal failure, carbonated, aspirin, acetylation, increased HbF levels, and iron deficiency. So before deciding exactly what is the status of HbA1c in a particular patient, we have to look for these associated conditions. Now, sensitivity and specificity of HbA1c at various cutoff levels in NDM subjects. You can see that. Cutoff level at 6.1, the sensitivity is 81% and specificity is 81%. If the cutoff level is taken as 5.7, the sensitivity is 92, but specificity goes down. So you can see in this table that as the cutoff level increases, the sensitivity decreases and the specificity of this particular test that increases. Now, there are certain errors in the diagnosis. Biological variations, there may be intra-individual, inter-individual, and day-to-day variations. Then there may be pre-analytical variations like pertain to the specimen before it is measured, and there is analytical variations like differences resulting from the measurement. So we have to look for these errors in diagnosis also. Now what are the implications? It affects the treatment choices and the risk management. It can have psychological and financial implications on the patient, and it undermines the quality of care and research. Now the biological variations in the glucose and HbA1c. Intra-individual variation in glucose in a healthy person is between 5.7 to 8.3%, and inter-individual variation is up to 12.5%. In HbA1c, the intra-individual variation of A1c in healthy people is minimal with CV of less than 1%, and the variability between individuals is greater. The other important factors is the diurnal variations. The NHA-NES third, based on the fasting plasma glucose, the prevalence of diabetes in afternoon half than that in the morning. Time to analysis, the plasma glucose decrease in the test tube by 5 to 7% per hour due to glycolysis, and the nature of the specimen, plasma glucose in whole blood are 11% lower than that in the plasma capillary. This plasma glucose can be 20 to 25% higher than venous plasma glucose during an OGTT, and this is the point when our patient asks that I did in the morning, my blood sugar at home was this much with the capillary method, and when I went to the lab, the values came to this. So this should be considered, and this is the answer for that. Now the pre-analytical factors, glucose, acute increase in plasma glucose concentration in acute illnesses and major surgeries, then corticosteroids, sympathomimetic drugs, isoniazid, olanzapine, digoxide, and niacin are the other medicines that affect the values. When we talk of the pre-analytical factors, glucose, acute decrease in the plasma glucose concentrations, the physiological factors in pregnancy, prolonged fasting or starvation, and intense exercise. These are the physiological factors which decrease the plasma glucose concentration. In acute illnesses like sepsis, acute renal insufficiency, and the adrenal insufficiency, the other drugs, the oral hypoglycemic agents, antibiotics like ciprofloxacin or gefloxacin, quinine and chloroquine, salicylates, and the alcohol. Then the spurious hypoglycemia is the prolonged storage of blood sample and the leukocytosis and the leukemias. So all these factors should be considered when we decide. Then within the lab imprecision, the analytical variability is considerably less than the biological variability, which is up to 8.3%. Different calibrators and the inter-lab differences are also there. Now, defining the medication errors, any preventable event that may cause or lead to inappropriate medication use of or patient harm, such events may be related to the professional practice, healthcare products, procedures and systems, product labeling, packaging, nomenclature, dispensing, distribution, administration, education and monitoring. So there are very many preventable events. They can all be prevented. Now when we classify the medication errors, circumstances exist for potential errors to occur. An error occurred but did not reach the patient. It was corrected even before. Error reached the patient but did not cause the harm. Patient monitoring required to determine lack of harm. Error caused temporary harm and some intervention, and then the temporary harm with initial or prolonged hospitalization. Error resulted in permanent patient harm. Error required intervention to sustain the patient's life, and error contributed to the patient's death. So we can see here from a very trivial factor, we can go up to the death of the patient. So we have to be very, very cautious in prescribing medicine to the patient. The patient should be seen in total. The holistic approach in patient management should be there, and treatment of diabetes, management of diabetes of any patient is tailor-made. Now, some reasons errors occur. Verbal orders. In the hospital, we simply ask the sister or the junior that do this. Poor communication within the healthcare team. Poor handwriting. We doctors are famous for poor handwriting. Improper drug selection. Again, we have to look for which drug causes drug interaction. Which two drugs should not be combined. Missing the medication. Incorrect scheduling. We have personally seen with big cardiologist patient going for the follow-up, heart failure patient, that time Lasix was being given. Writing Lasix was missed by the doctor somehow. And second day itself, the patient went into congestive heart failure. He was rushed to the hospital. He was intubated for 2 days, and that was the problem. And when it was analyzed why it happened, then it came to the point that Lasix was not written by the doctor by mistake. Polypharmacy, again in the elderly people, polypharmacy, and again, we physicians, we clinicians do not have time to look what patient is exactly taking. Patient going to 4 doctors, multiple doctors, no doctor has the time to see what the patient is being given by the another doctor for another problem. We have seen that patients are taking vitamin D, vitamin B12 from number of doctors. So please look for the polypharmacy and drug interactions, as I have already told you. Availability of the floor stock, no second check. Whatever is available is given to the patient. Look alike, sound alike drugs. Hectic work environment and lack of computer decision support. So these are the various reasons. So we should not do that. Now, treatment and the comments. When you write X60M, write proper and complete diagnosis like type 2 diabetes, obese or non-obese, microvascular and macrovascular complications and hypertension, associated comorbidities are present or not. So the diagnosis should be complete. Now you look on the left side, tablet glimepiride 5 milligram TID. I don't think this is the right dose. Metformin 500 ml BD or glimepiride glibenclamide 5 milligram BD and glimepiride 2 milligram OD. So two sulfonylureas being written together. The calories should be prescribed and the lifestyle management should be stressed upon by the doctor. Prescription usually silent. There is no ideal body weight written. What is the existing weight? What is the duration of diabetes? What is the type of diabetes? Associated illnesses, complications. What were the previous A1C values? How the patient is improving or deteriorating? And what is the drug history of this patient? And very important is, what is the drug allergies? We must always ask the patient that, do you have any drug allergy? And it should be documented. Now, there are certain omissions which we look. Time of medication is not written. Targets, what are the targets? Follow-up duration, when the patient has to come back. Simply write follow-up as advised. Nobody knows what advice was given. Monitoring intervals and the self-care should be demonstrated properly. A key component of reducing error in prescription is diabetes patient education. So there is lack of education. We do not have much time. May reduce slips and lapses in prescription about disease, the medication, benefits and side effects, and the complications of diabetes. Now, clinical examination, if you talk of height and weight, they are not measured. BMI, calorie calculation, choice of therapy, whether the patient is obese or non-obese. Now, waistline is not measured routinely. Non-obese but centrally obese correlates with insulin resistance. And the peripheral pulsates are not palpated. Carotid brew, surrogate markers of coronary artery disease, the posterior tibial, peripheral vascular disease, renal brew, renal artery stenosis, caution for use of ACE inhibitors, and especially at the present time when we talk of Sglt2 inhibitors, patient education is a must. Otherwise, patient had genital infection, especially the female patients, they led up with the gynecologist, and many of the gynecologists even do not know, I'm sorry to say, that this is because of the side effect of this particular Sglt2 inhibitor. Patient comes to you after 6 months, डॉक्टर साहब मेरी शुगर एकदम ठीक चल रही है बट एक नई प्रॉब्लम गायनी की हो गई है एंड व्हेन यू से दैट दिस इज बिकॉज ऑफ दिस ड्रग एंड व्हाई डिड यू नॉट टेल मी आई एक्सप्लेन्ड यू इन एडवांस so if that is explained to the patient properly, modestly, many things can be prevented. Foot examination, it hardly takes 2 minutes for a complete foot examination in a diabetic patient. We do not say that you go for a peripheral Doppler every time or you go for a biothiometer every time. Just put your fingers on the feet of the patient. Usually ignored callosities, the nails, pulses, arcs, major cause of mortality, and the fundus, hardly any physician is examining now. But at least once in 6 months, you should send your patient to an ophthalmologist for a complete eye examination when there is retinoscopy, tonometry, the equity of vision. So most common cause of painless blindness to be seen with the dilated people. Now what is our target? Blood glucose, HbA1c, but now the target is different. We have to look for all other comorbidities also. The fasting plasma glucose, we all know, less than 100 is good, acceptable is less than 130, postprandial less than 140 and less than 180, HbA1c less than 6.5, less than 7, triglycerides less than 150 but up to 200 it is okay, LDL less than 70 up to 100 it is okay, and the urinary albumin less than 30 but 30 to 100 when there is microgliuria, then definitely we should look for. The GDM indications for tight glycemic control. GDM post-renal transplant patients, acute myocardial infarction and stroke, and all young diabetics. Now, stressful situations in diabetes, the MI, sepsis, oral hypoglycemic agents are continued. Always switch to insulin. The Digami, Vandenberg et al., consistent and predictable pleiotropic effect is there, anti-inflammatory, vasodilatory, and no synthetase activity is there. Now, monitoring of diabetes. Fasting, intensive control, 4 to 7 point profile, postprandial 2 hours, conveniently controlled, conventional control, initially weekly, once stable, then we can go for fortnightly. HbA1c at least once in 3 months, lipids once in 3 months, microalbuminuria in the urine at least once in a year. If they are normal, if they are not normal, if microalbuminuria is present, then at least once in 3 months also it should be done. Fundus, if normal, once in a year, if abnormality, as per direction of the ophthalmologist, and foot examination, complete foot examination once a year. But every time patient comes, please look at the skin of the feet, please look at the foot, whether the patient has any skin changes, is there a hair loss, is there edema or any cut or anything is there, please look at that. Now the standard approach to therapy results in prolonged exposure to elevated glucose, and we can see that the diet, exercise and then sulfonylurea combination therapy, but now it is changed. Why I am putting this slide? Because we have learned all these things. Now as Dr. Devaskar told us that after lifestyle management, start with Sglt2 inhibitors, start with GLP, and then metformin has again come as the second line, and this has been approved by many authorities also. Now glucotoxicity, lipotoxicity and progressive beta cell function, combination therapy, target early euglycemia and prevent cost of complication, monotherapy to avoid side effect and cost. So tailor-made the management of a diabetic patient, which patient needs what. Please do not do any harm to our patients. Now if you look at that, HbA1c deteriorated to more than 9% before therapy intensification. The second agent was not added until an average of 30 months after the first HbA1c level of more than 8% was recognized. So this is basically a sin. This is highly relevant because the time spent in a hyperglycemic state is a key determinant of the risk of developing diabetic complications. Lifestyle modification, of course, advised after evaluation for dyspnea for exertion, peripheral vascular disease and obvious foot diseases, proliferative diabetic retinopathy. We have to look for 4 kilometers in 40 minutes, 7 days a week. If not 7 days, at least 5 days a week must be there, and it should be at a stretch. Time of administration of the drugs, a carbo just before a major meal or in between the meals. Glitazones anytime before meals, metformin with or immediate after meals, regular insulin 30 minutes prior to meal, short-acting insulin analogs 5 minutes before the meals, and long-acting insulin analogs, there should be a fixed time. And the best responders to sulfonylureas when the diabetes duration is more than 5 years, but this I will not discuss in detail because now the algorithms are being changed. Now look at this at least. Glibenclamide 10 milligram optimal dose, frequency is BD 30 minutes prior to meal. Glipizide 20 milligram, then gliclazide 160 milligram, and glimepiride is 4 milligram. We have seen prescriptions of glimepiride up to 8 milligram, 4 milligram morning evening. If glimepiride does not work with 2 milligram morning evening, it is not going to work in high doses also. So please look for that. Now combination of sulfonylureas, as I already told you, glibenclamide, glimepiride should be avoided. Hyperinsulinemia, weight gain, insulin resistance, and the beta cell exhaustion will further increase. Metformin with or after meal, sustained release can be given once a day also. Glitazones, obese type 2 diabetes better respond than non-obese. Improved insulin sensitivity despite weight gain, adipocyte differentiation, fat still phenomenon, and redistribution of the body fat has been observed. Acarbose and metformin combination both increase GLP-1, worsening of GI intolerance if there acarbose induced hypoglycemia, treatment with table sugar, which is important, and we should be treated with glucose. DPP-4 inhibitors, a new class of drug, now it's not new. Glucose dependent insulin secretion decreases glucagon, beta cell neogenesis is there, should be used as an add-on to metformin. Delayed use should be avoided. Why I am telling you? Because we cannot put every and other patient on Sglt2 inhibitors and the GLP-1 receptor agonist. Whatever the algorithm, whatever the these institutions say, because we are from a country where economy is also very, very important. So look for that. If there are 2 sulfonylureas available and if there are no major changes, go for a cheaper one. Now look at this patient, 45-year male, type 2 diabetes, obese, duration of 8 years, on tablet gliclazide, metformin and pioglitazone. This patient is obese. Now we know what about pioglitazone: water retention, weight gain, So addition of two sensitizers to different class is reasonable. First try full doses of metformin and later add glitazones or half of the doses of both to begin with. Sign of evoluting beta cell exhaustion has to look for. Early insulin therapy is always advantageous because there is beta cell preservation, smooth and stable glycemic control. There is less of glycemic variability. There is increased time in range. Weight gain and hypoglycemia events are lesser if insulin is used properly. Restoration of beta cell glucose axis. Insulin, do not mix two different type of insulin. In that case, use premix. Do not share syringes. Use strength U40 or U100. Use needles, once needle in tip bands, hooks or bracts. Fill syringe with head, and now pens are available and we are using the pens also. Sulfonylurea with regular insulin. Very dangerous combination. Patient may go into hypoglycemia, but they are given pre-meal along acting insulin in old age or renal failure patients. Definitely patient will go into hypoglycemia. So please keep a watch on the dose of the patient. Detimir and glargine are the clear insulins. Nil orally administration of insulin in certain conditions, and sliding scale episode of hypos there, and sliding scale insulin therapy has nowhere been mentioned in any of the textbooks or in any journal, so please do not use that. Insulin analogs to be used, selective subset of patients, short-acting analogs or school-going children, busy executives, RT feed, long-acting analogs, elderly, ICU setting, and brittle diabetes. Now I will not talk about the pumps because Dr. Manoj Chawla is here to talk about the pumps. Now these are the various injection sites in diabetic patients. Lipids and type 2 diabetes. Targets are not defined. Lipid Association of India says lower the better. You can go up to 30. The other associations, they say that up to 50 it is all right, but it is okay if you bring it down to 70. TG 150, SDL more than 45. Please do not treat triglyceride up to a level of 250 or 300 in a patient of diabetes when the diabetes is not under control. First start the statins, increase the dose of statins to the level it is required and tolerable by the patient, and then again look for the triglycerides whether they have really come down or not. Now BP is not monitored, BP in sitting position. At least once patient comes to us, we should check the blood pressure lying down, supine and standing, and at least once in both the limbs. Now non-specific selection of antihypertensives. This is again control of BP in type 2 diabetes, polytherapy, normotensimac. So this is in itself a different topic. Self-monitoring of blood glucose in type 2 diabetes, on OHAs, on insulin 4 times per week. Now others, superfluous errors like clinical trials may be biased. They are randomized clinical trials. We should go for real world evidences also. Diabetic experts and drug industry tries. Sorry to say, medications frequently influenced by pharma, affordability factors and compliance, role of chemists and drug distributors is there, alternative drugs claiming to be curing diabetes and the media hype. So these are the other superfluous errors. So, and you have seen this, US cracks down on Ayurvedic homeopathic diabetes remedies. Now key message is insulin and other anti-diabetic agents are a significant cause of hospital admissions. Medication errors involving insulin are responsible for a disproportionate number of serious adverse events. Several common errors are known to occur in the prescribing of anti-diabetic medications. Education and training may prevent some errors, and with that, I thank you all. Thank you very much.
Hello. Thank you, sir. Thank you. It was back to basics, but back to basics with a stalwart. And I'll ask my co-chairperson to further
I would like to invite Dr. Supratik Bhattacharya, sir, for the next lecture. He is the director of SKN Diabetes and Endocrine Center, Kolkata.
He is a consultant Department of Endocrinology and AMRI Solid and Apollo Sugar, Kolkata. He has a 30 plus international and national publications. He is the author of 5 books, and he has a lot of special achievements and awards. Over to you, sir.
with the entire team of Diabetes India 2022. And thank you, chairpersons, for the kind words of introduction. So, this is going to be my topic: glucose control today and protecting tomorrow. Your patients deserve all. And as you can see up there, that's my disclaimer. I've been contacted by AstraZeneca for this particular talk. So we know that the global prevalence of diabetes is on the rise, and by the time we come to 2045, the number is going up to 700 million, and Southeast Asia is a big concern because the number is going to go up by almost 74%. If you look at India, it's already number 2 next to China, and by the time it's 2045, we're probably going to be the global capital. Diabetes management change has been there in the focus, to moving away from the glucocentric to a more organ protection or organist-centric. And obviously, we have heard from the previous talks that there is a lot of cross-talk between the heart and the kidney, and this is the newest mechanism that has been proposed.
So one is the direct reductions in the oxidative stress, fibrosis, local inflammation, tubular senescence, etc. But at the same time, Sglt2 inhibitors can also cause natriuresis, which lowers the blood pressure to a modest amount, and also it ameliorates the volume overload, and in turn, this would result in intraglomerular pressure reduction. On the other hand, Sglt2 inhibitors also cause glycemic control and also caloric reduction, because you're peeing out glucose from the body, and because of that you have weight loss. Together, they probably have a renal and cardioprotective effect. So the glycemic, these are the slides that has been taken from Ralph DiFronzo. So this is the, if you're looking at the renal threshold, normally it's around 180. By the time somebody has got diabetes, it is pushed to around 220. Now look at what happens when you have dapagliflozin on board. So a person with type 2 diabetes and being treated with dapagliflozin, the renal threshold is pushed down all the way to 40. So a lot of glucose is peed out, and we know that hypoglycemia can never occur, because no matter how much glycosuria you have, that sends a signal which is mediated by the renal nerves, and this goes to the liver, which produces exactly the same amount of glucose that is lost in the urine. So the conclusion is Sglt2 inhibitors are not only now a diabetic doctor's molecule, but it's also being used very efficiently by our nephrologist as well as cardiologist colleagues. Again, this is a slide from Ralph DiFronzo, and as you can see in here, if you look at the ominous octet for diabetic nephropathy, you have various mechanisms like the hypoxia, hypertension, deranged tubuloglomerular feedback, podocyte dropout, for example, obesity, lipotoxicity. All of these pathophysiology is being addressed by the Sglt2 inhibitors. If you're looking at the pharmacodynamics, this is in a nutshell. So the total glucose loss by a Sglt2 inhibitor is close to 70 to 80 grams. Max HbA1c drop is almost 1%. However, I'm going to show you evidence. If you're starting with a very high baseline, you can have a bigger drop in the HbA1c. There's also osmotic diuresis. Calorie loss is equivalent to almost 300 kilocalories a day. Weight loss is about 2 to 4 kilos, depending on where you start from. The blood pressure reduction is to the tune of about 4 to 6 millimeter mercury, and also increased uric acid. Add-on therapy with dapagliflozin resulted, and this is the result coming in, versus the placebo. You can get a drop of HbA1c, which is almost up to 2%, depending on where you start from. Also, if you look at the pleiotropic benefits, body weight reduction, as we were talking about, can go up as much as 3.5 kilos, again, depending on the baseline. There's a recent study and an Indian study which shows that if you're using dapagliflozin, it improves the body fat patterning and hepatic and pancreatic fat in patients with type 2 diabetes. And it's only after a treatment of 120 days do you get to see that the mean liver fat decreases and mean pancreatic fat fraction also decreases with the use of dapagliflozin. While glucose control is fundamental to the management of diabetes, it does not necessarily translate into reduced heart failure events. And this comes from the various landmark trials. So we know that UKPDS, ACCORD, ADVANCE, whatever targeted only the blood sugar parameters or HbA1c did not translate into cardiovascular benefit. So optimal risk factor management does not eliminate the risk of diabetic nephropathy, and in spite of using the optimal standard of care, you still have a residual risk that remains. So the burden of cardiorenal disease in type 2 diabetes, and we know that there are some common factors which can affect people with diabetes, both on the heart and the kidney, and this could be the altered energetics, could be the hypervolemia, inflammation, ischemia, sodium retention, neurohormonal activation, or RAS activation. So again, as we were saying, there's a lot of crosstalk in diabetic patients. You have increased amount of heart failure and CKD. Similarly, there's a crosstalk between the heart and the kidney, and anyone with heart failure can have a worsened outcome when it comes to the kidneys. Similarly, anyone with CKD will have a worsening of the heart failure. So cardiorenal disease is the most frequent and first comorbidity that is observed with the type 2 diabetic patients. So almost 36% with CKD and 24% with heart failure. Prevalence and identification of CKD, and we know that in spite of having so many good molecules on board, the prevalence of CKD in patients with type 2 diabetes has been very consistent over time. Cardiac functions can be compromised very early in type 2 diabetic patients, and this comes from the left ventricular function in asymptomatic patients with type 2 diabetes. And there can be two mechanistic parts, one mediated by atherosclerosis, and the other one is completely atherosclerosis independent, and both can lead on to heart failure in type 2 diabetic patients. Now, if you look at the heart failure from prevention to treatment, we know that there is a long window. So dapagliflozin or other Sglt2 inhibitors can work all the way in those patients who have the risk factors but not an established heart failure. At the same time, it works well in those who had an event. So the DECLARE-TIMI was done in patients who had the risk factors, and also if you look at those with established heart failure, we have the DAPA-HF trial. So cardiovascular death and hospitalization due to heart failure composite, you see a benefit while using a Sglt2 inhibitor, irrespective of the presence or absence of atherosclerotic cardiovascular disease. Similarly, Sglt2 inhibitors have shown to prevent the occurrence of hospitalization to heart failure even in type 2 diabetic patients without established cardiovascular disease. So this is consistent both in the DECLARE-TIMI as well as the CANVAS program. So let's look at the prevention of the cardiorenal outcomes and prevention of kidney disease in particular. So DECLARE, it was different. How? Because it enrolled patients early in the disease continuum, including those without atherosclerotic cardiovascular disease and with predominantly preserved renal function. So if you're comparing DECLARE to CANVAS and EMPERAGE, you see the EGFR was higher, the mean EGFR was higher as compared to the population that was recruited for CANVAS and EMPERAGE. Similarly, if you look at the urine ACR, it was better in the DECLARE trial as compared to CANVAS and EMPERAGE. So DECLARE showed that DAPA slowed the renal disease progression in spite of starting off with a higher EGFR, and the risk reduction was to the tune of 47%. DAPA had favorable effect on the albuminuria across baseline, all urinary ACR categories, including patients with normal albumin excretion. So whether you're talking about reversal of the stages, micro to normal albuminuria, or macro to micro, you see benefits versus placebo. Similarly, worsening of the microalbuminuria stages were less versus placebo with the use of dapagliflozin. Prevention of hospitalization for heart failure, again, as I want to mark, see blue denotes those patients who had all the risk factors but did not have established atherosclerotic cardiovascular disease, and this population was higher in the DECLARE-TIMI trial as compared to, say, for example, EMPERAGE trial, which recruited more than 99% with an established event. So this broad cardiovascular risk population, DAPA demonstrated significant reduction in the composite of hospitalization due to heart failure, cardiovascular death, and fewer MACE events. So composite, you see the risk reduction, hazard ratio was 0.83, meaning 17% risk reduction. And MACE, although it was not significant, there were fewer numbers versus the placebo. We definitely had a benefit when using dapagliflozin in those patients with reduced ejection fraction, and this comes from the dedicated heart failure trials. But even in the DECLARE trial, you see clear benefits of using dapagliflozin in terms of heart failure outcomes. When it comes to the adverse events, we know that canagliflozin had concerns like, for example, fracture and also amputation. This was not seen with dapagliflozin. So if you look at DECLARE-TIMI, DAPA-CKD, which is a dedicated renal outcome trial, or DAPA-HF trial, we do not see any triggers where there was any increased incidences of either fracture or amputation, as was seen in the canagliflozin trial. So the point is, dapagliflozin can be used in the entire disease spectrum, whether you're talking primary prevention or those with established cardiovascular disease, and this is not seen with all other molecules in the same class. So we had been seeing the guidelines, and we know that anyone with established heart failure, Sglt2 inhibitors are the drugs of choice ahead of any other molecule. Similarly, anyone with established CKD, you need to consider using Sglt2 inhibitors ahead of other molecules. And obviously, if you want to minimize hypoglycemia or cause weight reduction in those who are overweight or obese, you have to have either a Sglt2 inhibitor or a GLP-1 receptor analog on board. So if you're looking at all the boxes, if you're talking about the primary heart failure outcome data, DAPA is probably riding on the most amount of data. Mortality benefits that comes from reduction in the hospitalization due to heart failure, or in using in patients with HFrEF or reduced ejection fraction, primary renal outcome data, all-cause mortality reduction in CKD, and also reduction in hospitalization due to heart failure and CKD progression. DAPA has got all the data versus the other molecules in the same class. So how to choose? Now we have generic DAPA, and why should you be sticking to the originator DAPA and not all the generics? So the reason is there is a drug development process that takes place, almost 3 to 6 years of preclinical studies, followed by clinical studies, which is almost 6 to 7 years, and then the regulatory review, which can be done at the end of 6 months or 2 years, and then the post-marketing surveillance. So this is the entire spectrum that goes on for developing an originator molecule. However, if you're talking generics, they will skip this 3 to 6 years plus 6 to 7 years of preclinical and clinical study, and straight away go for an abbreviated new drug application, which is required for the FDA. And if they're happy, they approve the drug, and all you have to do is prove that it's safe, effective, and lower cost as compared to the originator molecule. So in the process, what you're doing is only sticking to the post-marketing surveillance, talking about the safety and matching the efficacy. So you're missing out on so many years of preclinical and clinical studies. So another big concern is pharmaceutical equivalence, which means stability and dissolution testing does not equate to bioequivalence, which means blood concentration of the drug in the healthy volunteers. Similarly, bioequivalence is not equivalent to therapeutic equivalence. That means what is the actual outcome in the patients. Another very interesting fact is about the stereoisomers. So spatial arrangement of an organic molecule are different than another if an atom is shifted in any three-dimensional direction by even a degree. So this opens up a variety of possibility of different molecules, each with a unique placement of atoms in three-dimensional space. And chirality means mirror image. So a mirror image is not the same as the real person. Similarly, if you have a mirror image, you can't say that this will be as effective as the other molecule, as the original molecule itself. So two enantiomers of a chiral drug may differ significantly in terms of bioavailability, rate of metabolism, metabolites, excretion potency, selectivity of receptors, and toxicity. So DAPA happens to be a chiral molecule with 5 stereogenic centers, and the right stereogenic center is the key for its bioavailability, rate of metabolism, metabolites, excretion potency, etc. And that might not be the case when you do not have that exact stereogenic center with the generic dapagliflozin. So that might be flawed completely. So can cardiorenal benefits with originator DAPA be extrapolated to the generic DAPA? Again, a big concern. We know we have all the cardiorenal data with the originator molecule. However, I do not think it can be extrapolated to the generic DAPA unless they are doing their own dedicated cardiovascular outcome trial or renal outcome trial. So with this thought, I want to end. All that glitters is not gold. So thank you.
Thank you, sir, for the wonderful talk. I would like to invite Dr. Sanjeev Pathak for his presentation. Dr. Pathak is a senior dietitian from Ahmedabad. He is only postgraduate reading in dietetics from Oxford, which is working in dietetics center. He is principal investigator in more than 30 global clinical trials, including the new innovative trials, recipient of multiple awards, scholarships, and specificity. Several publications, his first author to author in the leading journal for diabetes for the world. He is a life member of various associations, ex-president of Association of Physicians in Ahmedabad, director of Diurnal Variations in Ahmedabad, and he is the first diabetologist to start insulin pump therapy in India. And he has developed and published unique diabetes motivational health report, the Blue Index. These works are Dr. Pathak. Good afternoon, and thank you for your kind words. I must thank Dr. Bansi Sabu, Dr. Manoj Chawla, Dr. Arvind, and the full organizing team of Diabetes India for giving me this opportunity. I will be talking about diabetes with cardiovascular and coronary artery disease, managing early, whether it has any. But in continuation with what Dr. Sympathetic and Dr. Mangesh said, that early control and control with the agents that just do not control glucose but also have other effects, especially the cardiovascular effects, is the way forward in diabetes management. And that is why Sglt2 inhibitors, GLP-1, all these have become the preferred drug in the management of them. I will be taking away from the glucose control to some other things which are also equally probably more important in the management of type 2 diabetes, especially for preventing or for managing the cardiovascular disease. Scenario is not uncommon in our practice. The young gentleman, even if he is uncontrolled, his BMI is not that high, his lipids are abnormal, he has been given anti-diabetic therapy but has never been treated for his lipid abnormality or for the other things which inhibit. Let us discuss about this. We know that cardiovascular disease is the leading cause of death in India, and about majority of the cardiovascular disease, it is the lipid abnormality that is the most responsible primary thing. Amongst the lipids, it is the lowering of the LDL which has been time and again documented to reduce the cardiovascular risk, both of our diabetic as well as non-diabetic patients. If you look at the left hand side, we know that a diabetic person without prior MI is having equal risk as a person without diabetes having history of MI. Of course, diabetes with prior MI,
the risk is multifold. And this is true as far as the lipid levels are also concerned, that at any level of LDL, the risk of a diabetic person developing cardiovascular disease is much higher. The pointer is not working. The risk of developing cardiovascular disease is much higher. So you can see here that in a diabetic person, even the LDL of less than 80 is responsive for a significantly higher number of cardiovascular events. So appropriate management is required for both, for coronary artery disease as well as for preventing coronary artery disease by treating dyslipidemia, and the Indian phenotype needs to address both the cardiovascular disease as well as dyslipidemia. Now let us talk about the sympathetic overactivity that exists in our population, especially the diabetic population. Stress, we very well know that it affects Indians to more extent than the Caucasians. 9 out of 10 of our people are having some form of stress. And 1 out of 2 Indians feel that they do not feel sufficient time for social activities because they have to work so hard to meet the ends. And in that process, they do not allot sufficient time for their hobbies, they do not allot sufficient time to the family. Moreover, in this COVID pandemic, this stress has increased significantly. Amongst the hypertensive people in India, about 62% of the people are having increased sympathetic activity. And stress, diabetes, smoking, obesity, all this adds to this sympathetic overdrive. And this sympathetic overdrive is associated with not only increased heart rate, but also multiple cardiovascular risk factors. And that accounts for hypertension, insulin resistance, obesity, subsequently the coronary events, even sudden cardiac death. The increased heart rate, on the other hand, caused by the sympathetic overdrive, will lead to arterial wall stress, endothelial dysfunction, atherosclerotic plaque formation as well as rupture, leading to events, sudden death, or even heart failure. So sympathetic overdrive definitely exists and is responsible for the cardiovascular event. In diabetic people, this sympathetic overdrive is even more because of the insulin resistance, inflammation, more norepinephrine release, and all this again increase the sympathetic drive. Compared to the person who does not have hypertension or diabetes, a person with diabetes has more sympathetic overactivity. A person with hypertension is also having more sympathetic overdrive, and a person who is having both hypertension and diabetes is having significantly increased sympathetic activity. What are the symptoms of sympathetic overactivity? Well, tremors, restlessness, inappropriate sweating, and one interesting symptom which is mentioned here is fast speech, and that you must have experienced in your busy clinic hours when there is significant amount of people waiting in your waiting room. Then your speech becomes fast and loud, and that is one of the interesting signs of sympathetic overactivity. Moreover, from cardiac perspective, it is reflected as in elevated heart rate. And you can see here that elevated heart rate more than 100 is associated with a robust increase in the cardiovascular events rate compared to the heart rate of less than 60 or 70. In this slide also, you can see that the beautiful study also showed that heart rate of more than 70 versus heart rate of less than 70, there was 34% increase in the risk of cardiovascular death, 53% increase in the heart failure, 46% increase in the myocardial infarction, and 38% increase in the coronary revascularization, which means that the elevated heart rate, even more than 70, is significant enough to increase the cardiovascular risk. We know that the first and the second line drugs which are recommended for diabetic patients with hypertension are ARBs, or in addition to that either a diuretic or a CCB. Having said that, in a patient with increased sympathetic activity, there are sufficient evidences, more so in patients with angina, post-MI, heart failure, and people with elevated heart rate, that even beta blockers can be considered along with the other drugs, because beta blockers can be combined with any of the drugs which I already mentioned. And this is label 1A indication. How do beta blockers help? They reduce the sympathetic stimulation, they reduce the heart rate and cardiac contractility, and they reduce the myocardial oxygen demand. All of you do not need any further education regarding the beta blockers' utility in patients with cardiac disease. That is very, very well evidence-based. Amongst the beta blockers, it is the metoprolol which is tried most, and in this study, which is long back done, it showed that it reduces the all-cause death by about 22% compared to the diuretic therapy, and the sudden cardiac death by about 30%. Among all the metoprolol preparations available, choosing the beta metoprolol with the MUPS-ZOC, that is multiple unit pellet system technology, giving zero order kinetic, gives the desired constant plasma concentration for 24 hours compared to the generic metoprolols, because in most of the generic or the gel matrix system developed metoprolol, the drug gets released in about 10 hours. More than 90% of the drug gets released in 10 hours, and so the efficacy does not last for full 24 hours compared to the MUPS-ZOC technology where the efficacy lasts for 24 hours. The key benefits of this type of metoprolol is that you can truly give it once a day, and so the compliance will be better. The therapeutic plasma concentration is smooth and uniform for 24 hours. There is higher beta-1 selectivity, and that's why less side effects, higher degree of response amongst the hypertensive patients, and the ethyl cellular polymer outer membrane prevents the impact from the physiological factors so that their absorption is not affected by food intake, pH of body fluids, and other co-administered drugs. And that is why this type of technology is preferred as far as the metoprolol is concerned. Coming to the dyslipidemia management in our diabetic patients, we very well know again that diabetic people are at risk of cardiovascular disease even before the clinical onset of diabetes. And that is why the therapy should be started as early as possible rather than once the plaque has already developed, and once it ruptures, it leads to a sudden cardiovascular event. It is not only the level of cholesterol which is important, but the duration of the exposure to LDL or cholesterol is also very, very important. The lower the age a person gets exposed to the cholesterol, higher is the risk. And that is why the therapy for the lipid lowering should be started as early as possible. This is a very good representation in two models. The model A, that is the benefit that is achieved by lowering the lipids once the plaque has already developed. At that point of time, it will just prevent the plaque rupture, or it will do the stabilization of plaque. Whereas the model B shows that you give the statin therapy even before the plaque has developed. And you can see the results of this study. The 30-year risk, you can see here that in the model A, when the statins were given after the plaque had developed, the risk avoided was 20.8%. Whereas in the model B, it is about 44%. That means the early initiation of statin therapy in a person who is at high risk of developing cardiovascular disease, as for example, any diabetic person, is definitely having significant evidence. How do we determine that this person is already having a plaque? I think at present, coronary artery calcium scoring is one of the best markers. Very economical, relatively non-invasive, requires very few amount of radiation, and that should be, I think, advised to most of the diabetic patients at least once in 2 or 3 years. If the score is 0 and if the lipid levels are normal, you can still wait for the lipid lowering therapy. But once plaque has started developing, you should not delay the therapy. We know that the score more than 1000 is associated with very high risk of a cardiovascular event, but even score of more than 100 is also associated with significant number of people developing coronary artery disease. Lipid lowering therapy itself is responsible for most of the cardiovascular preventive strategy that you can do for your diabetic patients. The STENO2 study and the UKPDS risk engine developed from the UKPDS study and the STENO2 clearly showed that in a diabetic patient, about 70% of the benefit of the cardiovascular risk reduction can be achieved just by giving the appropriate dose of a statin. Well, this is pre-SGLT2 era. Now, after the SGLT2 era, probably SGLT2 inhibitors also have a significant role to play in preventing a cardiovascular event, but that is mainly for the heart failure and not for the atherosclerotic cardiovascular event. From atherosclerotic cardiovascular events, still, I think statins are the best drug to prevent that. Just 1 millimole, that is 38.7 milligram of reduction of LDL, will result in 24% reduction in the major coronary events, 24% reduction in the coronary revascularization, 15% reduction even in the stroke, and the vascular death, any death, major vascular events, they all are significantly reduced just by a reduction of 38 milligram deciliter lowering of LDL. What do the guidelines recommend as far as the lipid lowering is concerned? Both European Society of Cardiology and American College of Cardiology, the guidelines are that the LDL should be primary target. For our Indians, it is not just LDL, but also non-HDL, which is equally important. Lower the LDL, better it is. And both the guidelines emphasize for 50% lowering of LDL and also ask for the specific value of LDL reduction for further clinical action. In a diabetic person, regardless the patient is having lipid abnormality or not, regardless the patient is having coronary artery disease or not, they deserve a statin therapy. If they are having already a cardiovascular event, it has to be an intensive, that is high intensity statin therapy. Otherwise, you can go for either SCORE or ASCVD or QRISK, whatever is appropriate for our patients. In our clinical settings, I think it is the QRISK or JBS, which is more representative of cardiovascular risk, but correct me if I'm wrong. Dr. A.K. Singh is here now, so we'll have his comments too. We need to set the goal of 50% LDL reduction minimum, because you can see that compared to non-statin therapy, 50% reduction in the LDL is associated with 57% reduction in the event rate. Moreover, compared to just 20% reduction, which you can achieve with maybe 5 milligram Rozua or 10 milligram of Atorva, 50% reduction, you can see a significant difference. The number needed to treat changes from 63 to 26 once you achieve 50% reduction in the LDL. Now, amongst the statin, right now we know that we are all bombarded with the non-statin therapies like bempedoic acid. It's a good drug, no doubt, but at present it does not have a cardiovascular evidence till the clear outcomes are out. So at present, obviously, statin remains the gold standard. Amongst the statin, which one to choose? Well, I'll quote some of the studies. Uranus is a head-to-head comparison of atorvastatin versus rosuvastatin, and you can see that with rosuvastatin, the LDL lowering is much better. The LDL-HDL ratio is also much better, and the non-HDL, which is a co-primary target for our Indian patients, is also much better in the comparable dose. The number of patients who achieve the target is again better in the rosuvastatin group compared to the atorvastatin group. And in the Jupiter study, we know that even in the non-diabetic or IFG patient, the reduction of the cardiovascular event was very, very significant. 31% reduction in people with impaired fasting glucose, 49% reduction in people with normal fasting glucose. The Voyager analysis, it's a meta-analysis of different statins, Rozua, Atorva, Simva, and it also showed that rosuvastatin, even at 5 milligram, is as effective as 10 milligram or 20 milligram of atorvastatin and 20 to 40 milligram of simvastatin. Rosuvastatin 20 is as effective as 80 milligram of atorvastatin. So rosuvastatin is definitely much more potent compared to any other statins. And this is again a comparison done in Uranus, Andromeda, and Coral study, where again it has been shown that rosuvastatin has better efficacy in reducing the LDL as well as non-HDL, both in diabetic as well as non-diabetic patients. Moreover, the evidence of reversal of atherosclerosis is only there with rosuvastatin in the asteroid study. It showed 78% plaque regression compared to non-rosuvastatin therapy. Again, amongst the rosuvastatin, why choose the innovator or the research agent? Two reasons. One is that the purity is responsible for the expected efficacy, and the impurity that is there in many of the generic rosuvastatins is responsible not only for less efficacy, but also to its increased side effects. We very well know the presence of methylated impurity in generics, especially atorvastatin, subsequently losartan, valsartan, and ranitidine, this NDMA or the methylated impurities may be responsible for some of the side effects that are associated with these drugs. These impurities also affect the efficacy and stability, especially for the rosuvastatin. Stability is also affected because of the impurity. Is there any evidence that the generic statins will have more risk? This study done in Spain showed that compared to the innovator statins, the probability of suffering a cardiovascular event for generics was higher by an average of 31%. So it is better to use the innovator statins. Finally, to end, we know sympathetic overactivity is much more common in our Indian people, and it is elevated more so in diabetic people, obese persons, smokers, and due to stress. Elevated heart rate increases the risk of cardiovascular event and risk of cardiovascular mortality in patients who are young especially. Metoprolol is the drug which reduces the sympathetic overactivity, and it reduces the heart rate, it reduces the sudden cardiac death as well as all-cause mortality. Amongst the metoprolol preparations, preparations with MUPS-ZOC should be preferred one. Talking about the dyslipidemia, we know that LDL and non-HDL are the primary and co-primary targets for our Indian population. We Indians develop cardiovascular disease even at a lower LDL compared to the Westerners. Statins still remain the first line and the gold standard as far as the cardiovascular risk reduction and the lipid lowering is concerned. Among different statins available, rosuvastatin has highest number of evidences both in diabetic and non-diabetic people. Rosuvastatin help LDL reduction by about 52%, triglyceride by 21% in diabetic dyslipidemia, and compared to the innovator statins, the probability of suffering a cardiovascular event is higher for the generics by an average of about 31%. Thank you very much for your very kind audience. Thanks again.
Thank you, sir, for the session. Any questions?
Very difficult question to address. But we can give an example that if you go for outside eating, what do you prefer? Eating on a lorry or eating in a restaurant? Or when you buy a water bottle, what do you prefer? So, pani ka khela ya pani ki achhi bottle? Of course, having said that, in some patients, you have to consider the economy, and there you may have to prescribe the cheapest available brand. But in drugs like statin, drugs like Sglt2 inhibitors, and certain important drugs which will have influence on life and death, obviously, as far as possible, choose the oral. Okay, Dr. Latest thing is there, so we can have his expert answer. This is a very difficult question to talk. Are you convinced that genetic is all of these are given. Now, if anything goes wrong, then as a doctor you are liable to your patient that you have to originate and have to avoid it, right? As long as it is working for you, that's fine. If something goes wrong, nobody is going to take responsibility. Unfortunately, this question is often asked by people who come in Mercedes and BMWs, and not by people
Already going to back. Is what? As long as you are working with government setup, I think generic where you're fine. Somebody comes and challenges you, is there to do. If it is your private practice, somebody is going to comes and sues you, you have to pay. Nobody is going to fight that case for you. Government is not going to come back and save you. If you are working with work which is government able, if somebody puts a case on you, is the government going to come and save you? Yes or no? Is the government going to come and back you up? No. Your lawyer is going to do that for you. Only question I ask, are you convinced with the data that you have, or the data is different from? Okay, sorry to interrupt. Yeah, is earning. Hello. The point you, if you prescribe a genetic product, you will be sued, is incorrect. What? Think about which point are you mentioning to highlight? I was saying that once you say that if you do this, that's not correct. Gentleman was saying that all of those people see, we should not know everything. Okay? Yeah. That's what it is. The same time, that our question is, but he totally agree with you. So the point is, not all genetics are as good as the originator. At the same time, I personally believe if it is your personal practice and somebody comes and challenges you, you will have to answer for that. So are you going? No, no. So it's your choice. Nobody is going to tell you what to do. Sir, the point is nobody is going to tell you what to do. It is your practice, it is your choice. If you want to stick to generics, as long as it is working for you, that's fine. If it doesn't work for you, then it's okay. Excuse me. Unfortunately, this will never end. This is a debate that we are going to have. Can we take it outside during the coffee? Because I think Dr. A.K. Singh is here to start his next session. The debate will go on. We declare the session over. And I think the name of the game is the customization. So we have to customize the statement according to the patient, according to everything. Thank you very much for all these speakers, and we invite the chairperson for the next session. We are welcoming two chairpersons, Dr. Rukman Narkar and Dr. Sonali Bhojani. Dr. Rukman Narkar is the MBBS MD DM Endocrinology, SCB Medical College Pathak, and Dr. Sonali Bhojani is MBBS Diploma Dermatology, UK Post Graduation Diploma in Clinical Endocrinology.
Words, thank you organizer, Intrigue team, Bansi and organizing team of diabetes. It was good to see many people around here. Always fascinating to be on this side of podium. Long time in this meeting with each other and dissecting medical things. So I'm going to talk on topics we just debating about engineering. Here we have got one
relatively newer in the sense evogliptin. Before I start, I would like to know how many of you present here have used evogliptin in your clinical practice? Quite good. That's great. So you are aware about that. Now let me become a devil's advocate, to be very frank, to tell you where is the evidence. So we have got one cheaper DPP-4 inhibitor, which is an innovator product branded by Indian pharma company. It's available in the market. You have got number of DPP-4 inhibitor. You know, the second highest number of DPP-4 inhibitor is available in India after the Japan. At the moment, Japan has got 15 DPP-4 inhibitor. You would be surprised to know. All are selling good. That is surprising. And India is the second. DPP-4 inhibitor is going to remain, despite all evidence at the moment with Sglt2 inhibitor. Please, let me revise you. When it comes to glucose reduction, the Sglt2 inhibitor do have huge evidence with regard to protecting heart and kidney. But when it comes to glucose lowering, DPP-4 inhibitor has never ever been beaten by even Sglt2 inhibitor. That's the fact. I wrote one editorial on this DPP-4 and Sglt2, which will be published on 14th of June next month in World Journal of Diabetes, looking into where are the DPP-4 inhibitor in the Sglt2 era. So let's look on this particular evolving gliptins named evogliptin. What is the promise and potential of this newer, cheaper, it's not a generic, this is an innovator, cheaper DPP-4 inhibitor. Now, you know the evolution of different DPP-4 inhibitors. Sitagliptin was first to get FDA approval in 2006, and evogliptin was brought to India from South Korea. As you can see, was given DCGI approval in 2018. It is available in many countries now, many South American countries, including Brazil, Russia, of course in India, Japan, North, South Korea, everywhere it is available. The beauty of this molecule lies with the fact that this molecule was given approval with a hardcore evidence, unlike another cheaper variations, DPP-4 inhibitor, which is available in India, named tenaligliptin. I have no grudges whatsoever to tell you that tenaligliptin has got minimalistic data when it comes to glucose control. Although when India had tenaligliptin, DCGI had the approval, we didn't have that much data, but of late tenaligliptin has generated now head-to-head evidence even versus sitagliptin. But this molecule, evogliptin, born after fighting a 5 double-blind randomized controlled trial. In 4 trials, they fought with sitagliptin, and in 1 trial, they fought with linagliptin, and it came neutral. There was no difference when it comes to glucose lowering. So what is this molecule is all about? Let me quickly take you through some pharmacology. So for DPP-4 inhibitor, just a recapitulation, you must have heard this. This is X-ray crystallographic picture of DPP-4 substrate. And all DPP4 has to get bound to the two orange color prime, it's called S1 and S2. All DPP4 needs to get its attachment to the DPP4 enzyme through S2 and S1. Now, if the DPP4 has got any additional ability to get anchored into either S1 prime or S2 prime, they are called class 1, class 2, and if they are blocking even S2 extensive arm of the DPP4, they are classified as a class 3 DPP4 inhibitor. So this is the modern classification of DPP4 inhibitor. But it's mandatory that you need to get anchored to S1 and S2. Now, even if you have anchored into an additional binding site like S2 extensive, and you are classified as a class 3 DPP4 inhibitor, you can see sitagliptin, tenaligliptin, and evogliptin are class 3 DPP4 inhibitor because they binds to additional S2 extensive surface of DPP4 enzyme. Now, theoretically, you might assume that all three would be similar because they are binding to additional substrate of DPP4, but that's not the case. It depends upon the binding association and dissociation that makes a quality of DPP4 inhibition. I will tell you that despite that they all are class 3, but there is a difference between 3 DPP4 inhibitor as far as DPP4 inhibition is concerned. Now let's look into how selective it is, because to choose a DPP4 inhibitor, remember that treating diabetes is not a 7 days, 10 days antibiotic course, and even if it has got some off-label side effect, it won't be manifested in such a short span of time. But when you're treating diabetes for entire life and using a drug, you must know the off-target side effect of the drug. Now, this is important because remember that while controlling blood glucose, you need to inhibit DPP4, but not the other DPP substrate, because other DPP4 are physiologically required in human body for a normal homeostasis. And therefore, if you want to control glucose, you want to selectively block only the fourth enzyme, that is DPP4. You don't need to block other enzymes like DPP8 and 9, because in preclinical studies, in animal studies, binding to other DPP enzymes like DPP8 and 9 was associated with different side effects. Therefore, the scientists tried to bring a selective, or you can see super selective DPP4 inhibitor. When it comes to evogliptin, they are looks to be the ideal, and they are at par with the US FDA approved DPP4 inhibitor like sitagliptin and linagliptin, and it is far selective than vildagliptin and sexagliptin and even tenaligliptin, as you can see here, with regard to DPP4 versus other DPP enzyme, include DPP8 and DPP9. As I said, selectivity is important, and the least selective DPP4 inhibitor is, please remember, is vildagliptin and followed by sexagliptin. Now, you might say, then what is the difference between these DPP4 with regard to selectivity? This is one of the reasons as to why the vildagliptin has unfortunately been associated with highest skin reaction. Remember, the vildagliptin is not a US FDA approved drug. That is one single important reason as to why US FDA did not approve vildagliptin pending 12 years of petition from Novartis. Remember, Novartis is a European-based company, and they have got a EMA approval, but not a US FDA approval. Now let's look into their pharmacokinetic, important to know, because you need to know where from the drug is excreted, and therefore you need to reduce the dose in a different end organ damage, in particular kidney and liver. Evogliptin has got primarily hepatic excretion and very less renal, and they have been studied in patients with kidney disease and liver disease, and this is the study done in patients with kidney disease. It was published in one of the highest impact factor journal in the world. You can see in DOME in 2017. And they actually looked whether you need to reduce the dose of evogliptin in patients with different degree of renal dysfunction. And the study suggested that you don't need to reduce the dose. The only caveat of these kind of trial, which I always take into a face value, that they have got a very less number of patients in these kind of trial. But this is similar data is there with sitagliptin and linagliptin as well. you don't get a large number of patients in such a PK/PD study. Similarly, you have got this molecule, evogliptin, has got data in patients with liver disease, and they have been recommended to be used in mild to moderate. Remember, none of the anti-diabetic drug is currently allowed in patients with child-pugh class C, means severe hepatic dysfunction. Insulin is the only answer. But you can use in mild to moderate patients without any dose lessening in patients with mild to moderate liver disease. Now let's come to the clinical science. As a clinician, that's fine with pharmacology. Where is the evidence? You can see, unlike other competitive DPP-4 inhibitor in India, it has undergone a massive development program, phase 1 to 2 to 3, and you can see number of, I'm not going to bore you with all the studies. I will catch up on only the active comparator trial. Of course, you will beat a placebo. That's not the point. You need to have a head-to-head trial with US FDA approved drug. So I have chosen few studies. You can see there are 6 studies, of which 5 study is a head-to-head trial of evogliptin, done 4 with sitagliptin and 1 with linagliptin, and first drug is against placebo, upon which they got the approval in the Korea, and then it was brought to India by the Alchem. So quickly look into the data. This is the first study upon which they got the approval. Look at their publication in DOME in 2017, and they shown a superior reduction in HbA1c versus placebo. Not a rocket science, expected. However, this study get them the approval for the treatment in type 2 diabetes. The second study is a Brazilian study. You can see here, this was for Brazilian approval, and in this study, Brazilian people said do a study head-to-head with sitagliptin, and this is a double-blind. Remember, all these 5 trials are double-blind randomized controlled trial. It's not an observational study done in any registry base or in any private hospital. These are double-blind randomized multicentric trial. So this is a Brazilian trial that found evogliptin is as good as sitagliptin when it comes to HbA1c lowering, and they got approval in Brazil from this particular trial. Third study, this is interesting. This is a study that compared evogliptin with linagliptin head-to-head. It's a double-blind randomized controlled trial, and looked for other endpoint. And the primary efficacy of endpoint of this study was to look for glycemic variability between linagliptin and evogliptin. You can see head-to-head trial, first 12 weeks of double-blind, and then open level evogliptin 5 milligram in 100 patient, linagliptin 5 milligram in another arm. The primary efficacy endpoint was CGMS data, because we are looking for glycemic variability. And here is the result. You can see there was no difference between linagliptin and evogliptin in this head-to-head trial. This is the HbA1c lowering effect. I'm not reading into numerical. If you see numerically, it was better with evogliptin compared to even linagliptin. But I'm a people of science, believes in statistics. Numericals doesn't matter. If your p-value is not significant, you are drawn. So finally, evogliptin was as good as linagliptin when it comes to HbA1c lowering. Now, if you see the glycemic variability index, be it MAGE or be it a standard deviation of the glucose excursion, again, statistically, there was no difference between evogliptin and linagliptin. But again, if you are a little bit biased with numericals, it was even better with evogliptin compared to linagliptin. And this paper is recently published in DOME again, this evergreen study. Now let me take you a few studies that was done in a background metformin therapy, patient failing on glucose control on only metformin monotherapy, and then were either added evogliptin or sitagliptin, and here is the result. So this was the first head-to-head study between sitagliptin and a background metformin therapy, and you can see there was no difference in HbA1c lowering between, so the lower one p-value is difference between 2, which is insignificant, suggesting that adding either evogliptin or sitagliptin. Remember, this is not a generic sitagliptin. This is innovator Januvia brand from MSD was compared head-on. There was no difference in the p-value when it comes to HbA1c lowering between 2 DPP-4 inhibitors. This is Indian study the DCGI also asked for a head-to-head trial, and they compared head-on with sitagliptin 100 milligram, and you can see both lowered HbA1c very nicely, but when it comes to comparison between evogliptin and sitagliptin in Indian patient, there was no difference in HbA1c lowering. This is another head-to-head study, again on a background metformin, added either sitagliptin or evogliptin. This was done in Korea and Russia, and there was no difference in HbA1c lowering. So this is the fourth head-to-head trial between sitagliptin and evogliptin before it was launched, in India. So to summarize, there were 5 matches played. This is a summary slide for you. The 4 matches with sitagliptin head-on, double-blind randomized controlled trial, 1 versus linagliptin, and the end result is there was draw. Now the point is, if you have got a drug which is cheaper than the innovator drugs, both are innovator, as I said, and both the drugs has got similar efficacy and safety, one can challenge that why not one should use a cheaper drug compared to the costlier drug. But there is a catch behind that. Now, this is a slide to understand how to use different DPP-4 inhibitor. And this is a master slide in front of you to understand what's the difference between different DPP-4 inhibitors. As you can see, we have got this 7 DPP-4 inhibitor right now available in India. When you are choosing a DPP-4 inhibitor, the first and foremost important point is you need to know how much DPP-4 is inhibited by the drug. A drug like DPP-4 inhibitor has to inhibit DPP-4 by at least 80% to have a sustained DPP-4 inhibition, to have a sustained glucose lowering. Now in this row, the first row, you can see 2 drug unfortunately is somewhere has got a questionable DPP-4 inhibition. Is one, the worst was with the tenaligliptin. You can go through the Japanese PMDA approval, and it was maximum 65% with tenaligliptin, as if you compared with other DPP-4 inhibitors. When you're looking into selectivity, as I said, you don't need to inhibit other DPP enzymes to avoid untowards off-level side effect. You can see some drugs are pretty non-specific, and especially vildagliptin, tenali, and sexagliptin are non-specific DPP-4 inhibitor. There's no doubt about that. Dosing, whether you need once daily, and vildagliptin is only exception where it needs to be used twice daily. Many of you might be thinking that there is a vildagliptin once daily available in market. I failed to understand how come this drug was approved, and I'm responsibly telling you in this podium through the Diabetes India that there is no study done with vildagliptin 100 milligram once daily. And also I would like to tell you that actually Novartis made vildagliptin 100 milligram 20 years back, and they asked for FDA approval, but FDA thrown them out and said, go back, bring a 50 milligram twice daily. You know why? Because 100 milligram vildagliptin was causing a severe increase in liver enzymes, including hepatitis and jaundice, and therefore the drug was divided into 50 milligram twice daily. Sudden, I'm now seeing the people are back with the drug which was actually banned 10 to 12 years back by the FDA. I have no word to express when someone comes with me to say, sir, we have got vildagliptin 100 milligram. There is no evidence. I'd be happy to see where from they have DCGI got them approval. Dose alteration in renal disease. You don't need to reduce the dose of certain DPP-4 inhibitor. The linagliptin is well known to you, and also evogliptin, there you don't need to reduce the dose. Similarly with the tenaligliptin. In the liver disease, of course, vildagliptin is contraindicated in any degree of hepatic dysfunction. So if you have got even a patient with NAFLD with a increased liver enzyme, on paper you are not supposed to prescribe a vildagliptin if SCPT is 3 times higher than the normal. And of course, you can't use any drug in severe hepatic deficiency. HbA1c lowering, you can see I have put the reference as a sitagliptin. If you have got a head-to-head, they all looks to be pretty same. There may be 0.1, 0.2% difference amongst a few head-to-head trial, but by and large they are same. QT prolongation, cardiac safety is of utmost importance, and tenaligliptin is the outlier, and that because they do increases the QT interval prolongation. Even in a dose which are used clinically, if you read the paper, you know the highest driver of QT prolongation in a diabetic patient is hypoglycemia. So if you have got a patient on sulfonylurea and you are using even a teneligliptin 20 milligram, be careful that it might cause QT prolongation, because SU will cause hypoglycemia, which will prolong QT, and at the top of that teneligliptin will further prolong the QT. So be careful. CV safety, they don't have, many of them, they don't have cardiovascular outcome trial, and you can see I have mentioned the first 4, Sita, Tecos, Lina, Carolina and Carmelina, Sexa, Sebertimi, as you all know, LO has got examined. Neither Vilda, Tenali or Evogliptin has any dedicated cardiovascular outcome trial. Therefore, I don't know whether this last 3 drug causes increase in heart failure or not. Risk of heart failure, as you all know, Sexagliptin is contraindicated. They are black box warned, and same is with the Allogliptin, unfortunately, which is unfair, because in Allogliptin trial, there was no increase in heart failure. But the problem lies what there was increase in heart failure in patients who did not have prior heart failure. And therefore, FDA gave them also a black box warning. For Vilda, Tenali, Evo, we don't know. And finally, cost. In the Indian setting, if you see the last 4 DPP-4 inhibitor on the right-hand side, and if you have to choose between this, I would say that the best bet would be to simply see that the DPP-4, which has got a least purple colored marking, is the best DPP-4 inhibitor in the Indian setting, since you people are wise enough to choose between different DPP-4 inhibitors. Thank you very much for your patience listening.
Now, if you look into the basic pathophysiology of type 2 diabetes, first thing that happens is that we can see that the first phase of the insulin release of the beta cells is not there, and we have only the second. And if you can see that the first phase of insulin release, it will come within 2 minutes of ingesting a meal, and then it will continue to be for almost for half an hour. And this is a very, very important thing. The amount of insulin that needs to be released in the first phase is a very, very important to the post-pancreatic spike which can be reduced. Now, how is it we can prevent that? We have a second phase of insulin. Now, there are only 2 ways where we can which can secrete the insulin from the beta cells, which of insulin, or we have to have such a diet with low glycemic load, which doesn't
somebody becomes a diabetic today,
60. All of us know that. Now, this is very interesting actually. Pneumonia et al. Has clearly said that if your HbA1c is more than 10.2 and the component of fasting blood glucose contributed to HbA1c is about 80% and postprandial by 20% in Caucasian population. But that is not true in Asian population where they take a lot of carbohydrate. Even in fact, there's several studies have come in the Asian population where carbohydrate intake is very high, not only in India, in general the Asian population. They said even at the higher HbA1c of 10, the contribution by the postprandial is almost 50% of it, not 20 or 30, 25%. So we need to do that even at a higher, according to the Monier et al. Study, what they have said is that if you got a high HbA1c, address the fasting blood glucose. It doesn't say, the Indian phenotype is different, the Asian phenotype is different. So we need to address both fasting and postprandial even at higher HbA1c level. The thing is that, and a newly detected diabetic who has got HbA1c of 7.3 to 8.5, you can see that postprandial contribution to HbA1c is almost 80%. That's not even in Caucasian population. Even in Indian population, even at the higher HbA1c, there's a 50% contribution. As the HbA1c comes down towards 8 and less, it's going to be 80% contribution. Now, it's very important to note that if you keep looking into fasting hyperglycemia correction, you will ultimately land up in nocturnal hypoglycemia. Instead, when you have such a HbA1c reduction, if you can address the postprandial blood glucose, you can achieve better control of diabetes in the form of HbA1c reduction and also avoiding hypoglycemia. This is what we need to look into that. Now, of course, we can see that the IDF recommends that you can have diets with a low glycemic load. We can use alpha glucose inhibitors and glynates such as rapid-acting insulin secretagogues and short-acting sulfonylureas are also indicated. RSSD clinical guidelines says that very important that 2-hour fasting, 2-hour postprandial should be less than 160, and the same thing like what IDF has said that we have to have foods with a low glycemic load, and then you can see that the alpha glucose inhibitors and glynates and along with DPP4 inhibitors and GLP-1 analogs are the drug of choice to address the postprandial blood glucose. And now combination therapy with alpha glucose inhibitor with other agents may be considered for better control of postprandial blood glucose. This is what we are going to do. So if you look into the RSSD recommendation where we have to go for a combination along with alpha glucose, which is a molecule that can be beneficial in reducing the postprandial blood glucose. Now, there are several molecules, but initially I said that if you have a molecule which can address the basic pathophysiology of type 2 diabetes, where if we can restore the first phase insulin release and then also address the postprandial in a different way, and we are going to have that combination. And so use a combination of a drug from different classes which addresses the unmet need of this. Now what is it we can do that? You have insulin secretagogue in the form of ripaglinide, which is rapid in acting and very short acting, and which works for the first half an hour to 45 minutes or 1 hour, and then it will increase the insulin secretion. That's one way. So you can restore the first phase insulin to great extent. And you know that alpha glucose how it works. It reduces the or delays the digestion of carbohydrate, assimilation of carbohydrate and absorption into the blood, and so that you can delay the postprandial spike, and so that the second phase of insulin release which is there, which will address the postprandial hyperglycemia. This is what we need to look into that. Now look into the ripaglinide, how it can be. It is glucose dependent, more physiologically. Higher the blood glucose, it attaches the sulfonylurea receptor and increase more secretion. As the blood glucose comes down, also the action of the ripaglinide comes down. And then you can take that, it is taken along with the meal basically to address the hyperglycemia, and because it's very short acting, it doesn't work beyond 2 to 3 hours, it reduces the risk of hypoglycemia as well. And it improves the beta cell function in patients with type 2 diabetes, and as I said that it restores the insulin, first phase insulin release, and then they are as good as sulfonylureas in efficacy as well. Now you look into the O-glucose, we know that it inhibits absorption of carbohydrate, and then most important thing is that the glycemic excursions usually, which is responsible for glycemic variability, will come down, and then most important thing, it is extra pancreatic effect in the O-glucose because it doesn't work on the pancreas, so that you can see that the effect on the beta cells will not be there, and you can see beyond pancreas, so that it doesn't exert effect on the beta cells and exhaustion will not be there. Another thing is that something like a DPP-4 inhibitor, even voglibose can increase the GLP-1 levels, and so that it can also help in restoring the beta cell function, and as well as looking into postprandial hyperglycemia. So now, why should we combine these two? Because two different classes of medications, and why is it because of better efficacy together, and then it can restore, as I said, that first phase insulin release, and then also effective in reducing the postprandial blood glucose, and then there is no evidence of clinically significant pharmacokinetic interactions between ripagline and voglibose when they are combined as an FDC. And these are two different mechanisms, and so that these molecules supplement with each other and give better results for us. Is the treatment for postprandial hyperglycemia beneficial? Well, we don't have any great evidence to say that we know the association, but we don't have any. By treating postprandial hyperglycemia, whether we can bring down is a question mark. But if you look into contemplate from the earlier studies, like for example, if you take the STOP NIDDM trial, where it addressed the postprandial blood glucose with alpha glucosase inhibitor, it has reduced the hypertension, it reduces the risk of cardiovascular disease by more than around 58%. So if you can look into that postprandial hyperglycemia levels, and then probably it is going to be beneficial. Now, if you look into the ripaglinate CV safety, you can see that there is definitely shift towards the left, where it says that the ripaglinate is cardio safe compared to any other secretagogues. It seems to be a very good effect on the heart. It doesn't give any cardiotoxicity at all. Now, as far the efficacy is concerned, we have our own studies by Dr. Manoj Chawla et al., and you can see that they have taken about 200 patients, and then they have taken into two groups, that is ripaglinate with voglibose, that is RV group, what we call group A, and where you can see that they have put 0.5 milligrams of ripaglinate and voglibose 0.2, and then if necessary, if the HbA1c is more than 8, they've increased the ripaglinate to 1 and kept the voglibose as 0.2, and then group B only ripaglinate. Now it's a 6-week study, and then let us look at the results. What has happened was that higher portion, sorry, one more slide. Okay. And then definitely that postprandial hyperglycemia comes down, and then you can see that the proportion of the patients who responded to a combination therapy is far higher compared to 38% versus 52% actually. So you can see that. And there is one more study, this study what is already shown that there is a fixed dose combination of voglibose study, and which is about in 20 patients that they have done, and is published in the results here. You can see that there is insignificant weight gain, no side effects such as hypoglycemia, and then you can see that postprandial blood sugar is reduced by 60 milligrams, and that is very, very effective there. So a ripaglinate and voglibose combination was effective and safe for the management of postprandial hyperglycemia type 2 patients. There is one more study to look into the efficacy again. This is again a non-randomized, open-label, non-comparative, multi-centric study where 69 patients have taken and put on FDC of voglibose 0.3 with ripaglinate 1 mg, and then look for about 3 months, and then there is a significant reduction in post-fasting and as well as postprandial, and as well as in HbA1c reduction has been found. And without any major side effects actually. So are there any other, just because it addresses the postprandial hyperglycemia, this combination has got any other uses, especially elderly population in whom hypoglycemia is a concern, because it has got no hypoglycemic symptoms or minimal hypoglycemic symptoms, and then ripaglinate can be used in even in kidney failure. And patients taking low-dose sulfonylureas who encounter problems with hypoglycemia, this is a good choice that you can think. And patients with irregular meat pattern is also a very good choice for us to take. So friends, let me summarize to say that a combination therapy of non-sulfonylurea enzyme secretagogue ripaglinate with alpha-glucosase inhibitor will provide efficacy compared to the monotherapy, and both of them have different mechanism of actions. When they're given together, it's got a complementary action and it can prevent the postprandial hyperglycemia and deleterious effects on the endothelium as well. And there are no clinically significant pharmacokinetic interactions between lipaglinide and when it is combined as an FDC, and then combination was weight neutral and had fewer hypoglycemias than monotherapy. Before I finish, just to remind you, my friends, that we have, it's a 50th year. It's a golden jubilee year for RSSDI, and then it's a very significant year. I welcome you all for this meeting, which is on September 6, 7, 8, 9, 4 days. We're going to have an exciting scientific session, and a very comfortable stay will be there. And then as an early bird registration, it is available as 5,000 rupees instead of 12,000 rupees registration in this conference. And apart from that, if you're not a life member, if you become a life member before June 30th, you'll get the registration free. Just we wanted to increase the membership in RSS Day so that we'll be in touch with you. Thank you for your patience.
Thank you, sir, for a wonderful talk. I think with that we can move on to the discussion. So, the audience members, do they have any questions? Give the mic, please.
The questions for all the three?
Yes.
Yes, you're right.
So one question for Singh on chat. In your slide you had shown the IC50 was the lowest for every member. So that means you need, that drug is most potent amongst. So the good side and bad side. The good side is that therefore it will have less of adverse effects because you are needing quite a small amount of drug. But the DPP4 inhibition is 80%. I would have been happier if it was 90%. Would a higher dose would have achieved more than 80% inhibition of DPP4, or that is the ceiling? No matter what dose you use, that is the ceiling, regardless of the IC.
So you have seen the Hypoglyptin and linagliptin is pretty same. That's why they are the most potent and available in a 5 milligram. Both linagliptin and Hypoglyptin is a 5 milligram tab. Now, in their phase 2 trial, dose finding trial, they looked for whether increasing the dose would all further inhibit DPP4. And as you said, there was a ceiling, there was no difference even if you increase the dose to 10 milligram. And therefore this dose was chosen off. The point is, not necessarily a DPP4 inhibitor should have a DPP4 inhibition of 80% when you administer it. There has to be a sustained DPP4 inhibition over 24 hours of the time. And that's the reason why vildagliptin 50 milligram if you use once daily, their peak and trough effect is compromised if you use once daily. The moment you give 12 milligram vildagliptin, then it the entire DPP4 inhibition remains sustained. Now a DPP4 inhibition which is more than 90% when you take the DPP4, but their effect is not sustained by the next 24 hours, HbA1c lowering will be affected. So it's not only the percentage of DPP4 inhibition when the drug is ingested, but it is the entire duration of the time of the DPP4 inhibition. And here all sitagliptin, linagliptin, allogliptin, evogliptin, other than denaligliptin and sexagliptin all achieved more than 80% inhibition until 24 hours after the first dose administered.
No,
right, so I discussed, you are not present here, I discussed before I started my talk. So vildagliptin 100 milligram story is, I would say, little bit obnoxious. You have seen my post on different group. Vildagliptin 100 milligram do not have safety data. As I said in my talk, that vildagliptin initially by Novartis, who is the innovator of vildagliptin, they asked their US FDA approval for 100 milligram once daily initially. But because once a dose 100 milligram of vildagliptin was associated with increasing in liver enzymes, the US FDA returned them and they said that you come back with you divide the dose so that the liver enzymes gets better. And in 50 milligram twice daily dose, LFT elevation was much better compared to the 100 milligram. And therefore Novartis did not came with 100 milligram once daily. I am surprised how could DCGI give them a approval, how pharma company in India gets such kind of approval without any issue. I mean, so once you have given to one company, everybody will get that.
No, actually, Dr. A.K. Singh, actually, do you think that there is one saying that, belief that giving 50 milligrams twice a day will have a very good effect on the glucagon, so that postprandial blood glucose is much better controlled with twice a day rather than once a day?
Okay, we had, okay, number of taking the DPP. And
no, that depends on the. I agree.
our own educated, I mean, why should I offer you not by educating data by friend? Because of the belief that whatever pharma says, you don't agree.
Very good. Fine, please.
Sir, I have a question for you, Dr. A.K. Das. Sir, would you...
A.K. Singh, not
okay,
A.K. Das.
Singh. Would you summarize in one line as to how do we... Sir, we move on to our next question.
Guts to listen. First, what? Please. Okay, sir. So as you say, one need to understand. Useless, idiotic argument in the...
There are articles. There are articles. These are in
Don't create unnecessary in the hall. You know nothing. Huh? You know nothing. Your registration should be revoked.
Thank you. Sir, my next question to you. Sir, would you summarize in one line as to how to choose one DP4 inhibitor over the other within the class?
There is no one line, right? So we are learning 2006 once the one liner to choose. You have got some pros and cons associated with the different DPP4 inhibitor. Now you have got a data with the US FDA approved DPP4 inhibitor. Sitagliptin has undergone a CV outcome trial, it was neutral. Linagliptin has undergone a CV outcome trial, it is cardiovascular neutral. Sexa has gone neutral, signals of increase in heart failure. Elogliptin has undergone CV outcome trial, neutral, some signals of heart failure. The DPP4 makers, I mean when you're talking about tenaligliptin or evogliptin, they don't have any dedicated CV outcome trial. So we don't know yet whether these drugs have got any potential to increase in the heart failure. So simple suggestion, if you have got a patient with known heart disease or a known heart failure, don't use the drug which has not been studied. So these will be a typical patients where one should use either sitagliptin or linagliptin if you have got established cardiovascular disease. If your patient do not have established cardiovascular disease, you can choose between any cheaper gliptins provided they do not have a QT prolongation issues.
So for short of time, we would just close this session. Yes, we can discuss during the coffee time.
With that, we would like to conclude this session, and I thank all the speakers for this wonderful session. And with that, we can move on to the next session. For the next session, the chairpersons will be Dr. Rajesh Pattur Singh, who is MD from Goa Medical College, and currently the director of
Hello, namaskar, warm namaskar to all. I'm Rajesh from Goa and welcome to Paradise of India, Goa. So let's start our session today. We have Professor Dr. Rakesh Sahai, Professor and Head of Department of Endocrinology, Osmania Medical College and Hospital, Consultant Endocrinologist at SAIS Endocrine and Diabetes Center, Hyderabad, President of Endocrine Society of India, Vice President of South Asian Federation of Endocrine Societies. He has multiple awards in Sglt2. He has fellowship in National Academy of Medical Sciences, American College of Endocrinology, RSSDI fellowship, Senior Lecturership Oration of Association of Physicians of India in 2008, Best Teacher in Medicine from Government of Telangana. He has published more than 150 publications in various national and international journals and authorized various chapters in textbooks and monograms on diabetes. So, Professor Sai, over to you.
Thank you. Thank you, Chairpersons, for the kind words of introduction, and thank you to Dr. Manoj Chawla and the scientific team for giving me this opportunity to be here today and to speak about the relevance of premixed insulin in the Indian context. We all know that, while all the global guidelines speak about basal insulin and intensification with basal bolus therapy, our premixed insulin is very popular in our country. The usage of premixed insulin is quite significantly high, and I will speak about the relevance in the next 15 minutes or so. What I'll try to do is speak about the unique characteristics of Indian type 2 diabetes patients, the risks associated with uncontrolled hyperglycemia in our patients, and what is the context, relevance of premixed insulin today in our context, and take you through one or two case discussions to highlight the importance of premixed insulin in our practice. So if you look at patients in India, we are different from the Western phenotype, because we all know that we have been speaking to about this distinctive clinical phenotype of diabetes in India. We have a higher waist circumference, higher visceral fat, increased insulin resistance, and also coupled with the early beta cell defect. And this leads to high prevalence of diabetes at a younger age, as was highlighted by Dr. Jargar in the morning, and the high prevalence of coronary artery disease, a lower prevalence of peripheral vascular disease, and possibly slightly lower prevalence of microvascular complications. So we have a unique phenotype of diabetes in our country, and as we highlighted, the major factors being low lean mass,
with a higher fat percentage, as was shown by several different studies by Dr. Yajnik and his group. And so we have more of ectopic fat deposition, which leads to impaired insulin action and probably earlier beta cell exhaustion in our patients, and therefore indicating the need for earlier insulin use in our patients as compared to what we see in patients from across the world. So we find that HOMA beta levels were lower amongst South Asians compared with all other racial ethnic groups after adjustment for age and adiposity, indicating the need for earlier insulin use in our patients. Even our dietary composition is different, and that has been highlighted by this START study, we looked at patients across different parts of the country, the dietary consumption across different parts of the country, and we've shown that the carbohydrate intake across different parts of the country is the same, about 64-65% of carbohydrate intake, and clear non-adherence to the dietary advice in patients with type 2 diabetes. And this is probably one of the reasons why we have a higher carb content in our, higher postprandial glycemic excursion, as is seen in different studies. If you look at these studies from India versus the Caucasian studies, we find that postprandial hyperglycemia is a significant problem and contributes significantly to the HbA1c. We have the famous Monier's data showing that postprandial hyperglycemia is important when the blood glucose levels are lower, but in data from our part of the world shows that even at higher HbA1c levels, postprandial hyperglycemia is significantly high. So we know that postprandial hyperglycemia, Dr. Just now we heard about the higher, the risks of postprandial hyperglycemia, how we need to address it and all that. And so I don't need to elaborate these points again. But the important point I would like to highlight is that at any level of fasting glucose levels, if you look at the corresponding postprandial glucose level, if the postprandial glucose level is higher, then probably there is an significantly increase in morbidity, independent of the, so it's an independent marker of mortality. And when you're trying to target the postprandial hyperglycemia, you tend to get a better response in terms of the number of people who can achieve the HbA1c target as compared to targeting only the fasting glucose levels. And hence, in our population with a higher prevalence of postprandial hyperglycemia, with a higher degree of postprandial hyperglycemia, it makes more sense to target the postprandial glucose levels adequately in almost all our patients who require therapy, and particularly so when you're looking at insulin therapy, when using a premixed insulin. In that context, I'm going to speak about the role of premixed insulin in that context. So if you look at the timing of insulin therapy, also we know that all across the world this is a problem, that there is a significant inertia in terms of initiating insulin therapy, and in our country also we see that there is a significant inertia, and HbA1c levels are quite high, almost 9 or 10% before people are actually started on insulin, and this therapeutic inertia leads to a higher risk for development of complications. Timely insulin initiation, we have data from different studies which has shown that timely insulin initiation may have a significant benefit. We have data not only from India but across the world. You're seeing this study from Kamlesh Kunti et al. Who have highlighted the fact that there is significant inertia, and more than 41% of patients were having HbA1c of more than 9%, and almost 22% having HbA1c more than 10% when they were initiated on insulin. And similar data exists in India also. This is data from different studies, different insulin initiation studies. These are all real-world studies where insulin was initiated on patients who were uncontrolled with OADs, and you find that across the board they were above 9% when they were initiated. And if you look at from these studies itself, you dissect out the Indian patients and look at the Indian data, what we clearly see is that all these patients have a significantly higher higher postprandial glucose levels as compared to other populations. So we have data on the same study which is conducted across the different countries, and we see that Indians tend to have a higher postprandial glucose levels in this.
that also showed, this study again showed that there was a similar reduction with both HbA1c with both the types of insulin, a bit insulin doses were also not significantly different at the end of the study. So intensification with premix insulin is also possible when you're using this in patients who have been initiated on premix insulin. You could intensify with premix insulin also. It fares as good as converting them to basal bolus therapy. So this is looking at glycemic control improved with the use of premix insulin, the Lispromix 25 or insulin glargine with respect to the main meal timings. Both regimes can be used in patients with inadequate glycemic control who are in need for insulin intensification. So both of them work well. Now there is a meta-analysis also of 13 different RCTs which have more than 5,000 patients who are analyzed in this, and you look at the difference in terms of the HbA1c reductions and also the rates of complications like hypoglycemia or weight change, and we find that there is almost similarity between the two types of insulin, that is premix insulins are non-inferior or comparable to the benefits that you see with basal bolus insulin, with a the convenience of having just 2 shots as compared to the 4 shots with basal bolus insulin. Now, looking at some of the factors which will help us in choosing insulin therapy. So if we find that if we find that there is a significant postprandial increment, then premix insulin, prandial insulin is required in such situations, and therefore initiating with premix may be better than initiating with a basal insulin. And particularly also if you see that if the fasting plasma glucose by HbA1c ratio is less than 20. So these are some of the parameters that we can use to decide whether premix would be suitable in a particular patient. The difference between the bedtime and the morning blood glucose is more than 55, then consider prandial insulin, a premix insulin which has a prandial component. Then there could be other factors like psychological factors, like if patient wants a simplified regime rather than going for an intensive regime with the basal bolus insulin, then again you need to choose a premix insulin. And also some of the looking into some of the considerations of the fact that there is a considerable delay in initiating insulin, and there's a rapid progression in the beta cell decline, and because of these two things we need to address both the components, that is the prandial component and the basal insulin requirement in patients when you start off insulin, rather than just addressing the basal insulin component, which happens in most of the Western countries because they have a more beta cell function, and they probably having a significant decline in beta cell function when they initiate insulin also. So because of these factors, we find that premix insulin gets a preference in our country. Now, what are the global and Indian guidelines saying? If we look at the global and Indian guidelines, we find that there is a recommendation more for basal insulin amongst the guidelines like the ADA, the ACE guideline or the IDF guideline. Whereas if you look at the NICE guideline, it's more again looking at the importance of premix insulin. While they also advocate the use of basal insulin, they've also spoken at length about the use of premix insulin for insulin initiation and also for intensification. If you look at our own RSSJ guidelines and guidelines from countries like Malaysia, they recommend basal insulin, premix insulin or insulin co-formulation for initiating insulin therapy. If you look at the NICE guidelines, as I was mentioning, they have highlighted the need, the use of premix insulin as an option for initiating insulin therapy, and they highlight the need for considering twice daily biphasic human insulin regimes, in particular where HbA1c is elevated above 9%, and they also consider premixed insulins analogs rather than premixed human insulin preparations wherever possible, where financial considerations are not an issue. If you look at the Indian national guidelines, this was earlier in 2013 when they were brought out. They also spoke about the premix insulin being a safe and easy way to start and stay with the regime for initiating insulin and even for intensification of insulin. And similarly, we had the expert consensus in 2017, the premix consensus, which again spoke about initiating with premix insulin or as once daily, then going up to twice daily, or going to thrice daily when you're thinking of intensification. Even the ADA guideline, if you look carefully, you have a mention about premix being an option when patients who are not controlled on basal who need intensification. You could even think of premix insulin as mentioned as an option. Now quickly I'll just take you through two cases before I conclude. So if you look at this lady who's a 52-year-old lady who's been having diabetes for 12 years, HbA1c of 9.3%, and she has got a BMI of 26 kg per meter square, BP 130/90, eGFR of 74, and a significant lipid abnormality. So this lady has been on sitagliptin, metformin, glimepiride, 4 mg of glimepiride along with atorvastatin 20 mg, losartan and chlorthalidone. So now this patient is not controlled on OADs, needs to be initiated on insulin because you see that her HbA1c is quite high, and certainly you would like to start her on insulin, and the options that we have are going with either a basal bolus therapy because you see that her postprandial glucose levels are also significantly high. The other option is that if she has, because most of our patients would be reluctant to have 4 shots of insulin, so we often they would be more likely to accept 2 shots of insulin, and you start her off with premix insulin is a good option. So this lady was also started on premix insulin initially once a day, then increased to twice a day, and you see that over a period of time glimepiride was lowered and dose was discontinued, and at 3 months her blood glucose came down, her HbA1c came down to 7%, 6 months her HbA1c came down to 6.9%, and she was on Lispromix 28/24. So this clearly illustrates that premix insulin is a good option in most of our patients, even when they have significantly elevated blood glucose levels, HbA1c of 9.5%. This worked very well. So look at this individual who is 68 years with type 2 diabetes for 15 years, a BMI of 26 kg per meter square. Again, he's been on 3 medications: glimepiride 2 mg BD, vildagliptin 50 mg BD, 500 mg BD of metformin, and he's already on a Lispromix 24 units and 16 units, and his HbA1c is 9.2. So a good option would be to intensify to basal bolus therapy, also considering the use of Sglt2 inhibitors in today's scenario. And if you look at studies which have looked at shifting to a high mix preparation like Lispro 50/50, you find that there is data to suggest that you could have better postprandial glucose control with such a preparation, and you could achieve reductions in HbA1c without significantly increase the risk of hypoglycemia. And in this patient also, he was shifted to a Lispro premix 50 once before breakfast and continued on Lispro premix 25 before dinner. Dapagliflozin was added 10 mg once a day, and over a period of time his dose was up-titrated, and after 6 weeks he was stabilized on a particular dose of that is 25 and 26 and 20 units, and the dose of glimepiride was also decreased, and at 3 months his HbA1c did come down to 7%. So in these 2 cases which we see that there was a significant benefit with the use of premix insulin, and I would like to summarize by saying that there is in our patients a significant contribution from postprandial glucose levels even at higher HbA1c in our population as compared to Caucasian populations. Premix insulins are simple to start with single injections with effective HbA1c control, targeting both the fasting glucose and the postprandial glucose levels. Patients who are uncontrolled on 2 or more OADs with a flexible lifestyle can be started on premix insulin, and those can be titrated on a weekly basis. Premix insulins provide convenience and simplicity at initiation, titration, and intensification. Premix insulin provides both the convenience and efficacy to the patient and contributes a long way in achieving patients' glycemic targets. Thank you all for the patient hearing.
Thank you so much, Dr. Sahai, for that insightful talk. Next, Dr. Manoj Chawla.
Okay. We'll take the question now.
All right.
I may
So
not be able to stay.
Dr. Sahai will be leaving shortly, so if there are any queries regarding the premix topic, you can ask now.
prescribe ordinary mixed I mean the brown color mixed So is that when will you advise simple mixed forget about your sponsor as a teacher? For the intensity. Why is that like in the US? I'm sure that you are aware of the insulin cap. Why don't you tell them to cut down the price so that always the profit is in the bottom of the bit. Everyone enjoy your insulin. But why you people keep on?
Sure. Let me answer now. Yeah, please. The other one also you please tell me.
Oh, nice. The other one is.
Okay.
I'm sorry, you carry on. Carry on.
Yeah. So your point is well taken. As I was highlighting in my entire talk, is the fact that for convenience we prefer premixed insulin. Although physiologically you may say that basal bolus may be more ideal, but for acceptance, better acceptance and convenience, we use premixed insulin. Now the question of using analog versus conventional premixed. In my practice, most of my patients are on conventional premixed. I'm speaking about that only. In the entire talk, I have spoken about conventional premixed only. I've also highlighted the fact that guidelines across the world have said that there are benefits of analog premixed over conventional premixed. They have mentioned that. They have not said that you have to prescribe that to everybody. In patients who are having a problem with control of postprandial hyperglycemia, you often need analog premix. So there are some patients whom you need to shift to that, and in some patients in whom cost consideration may not be an issue at all, you may give them analog premix. But in those where you have a cost consideration, we prefer conventional premix. So that's what I've been speaking about. Yeah, so actually what happens is that you need to individualize that, because preoperatively it's a very different scenario in every patient. Every patient is not the same. You have somebody who's very poorly controlled going for a major surgery, and you may prefer to give basal bolus at that time because that is beneficial. You can adjust the dose, you can bring him to control, keep him in control afterwards when he's in the post-operative period. But there are some patients who are just going for a surgery which doesn't require maybe orthopedic surgery. His blood sugar levels are slightly high. Just give him premixed insulin, he is okay for a few days, and then he's back to his oral medications. Even if he's on 4 medications, that's fine, you can go on with that. People with cataract surgery on 3 medications, well controlled, you don't need to do anything. You just can allow them to go for surgery, and they could be continuing to be on their oral drugs. So that's the approach that we follow.
So we'll take one last question.
Yeah.
I am Dr. Kamavelu, practicing medicine for 5 decades. The choice of the premix, basal and other things, all the 6 readings what we get, pre, post. According to that, only we have to decide for each and every patient, either basal or single bolus alone, or basal plus 2 bolus, or basal plus 3 plus, or have we to set premix to 2 different doses. So all depends upon the readings of an individual by himself. Individually we have to decide. There is no standard rule to decide to be given to everybody. Depending upon the results of all the 6 readings what we get, we have to decide upon that patient whether basal with single bolus alone is enough, or basal with 2 bolus is enough, or basal plus 3 bolus is enough, or does he need premix twice daily?
Yes.
This is my opinion.
Absolutely, sir. What you're saying is absolutely true. That those are the factors that have to be considered. What we are also looking at is what is convenient, what is more acceptable to patients. You may find that a patient has got a high fasting glucose, high postprandial glucose, and he is not controlled. He is on, say, just metformin alone, and he has come to you. He is a person from a rural area who doesn't want to, do 5 readings. You have done 5 readings while he is with you, but he doesn't want to do the 5 readings every day, and doesn't want to, change his. He doesn't want that flexibility which you can provide with a basal bolus therapy, and he wants something convenient and something which is less stressful for him, less painful to take, I mean, less intensive therapy. So in such patients, what I'm trying to highlight is that premix may be a good choice, and that maybe many of our patients, maybe 60-70% of our patients may fit into that category. There will be some patients who certainly require more more meticulous care. In such patients, we should certainly take basal bolus, as you have rightly mentioned.
All right. Thank you so much, sir. Coming next, Dr. Manoj Chawla. It's my pleasure to introduce Sir. Sir is my mentor, and he, as such, doesn't need an introduction, but Sir is the organizing secretary for the World Congress of Diabetes India 2022. Sir is the director and consultant diabetologist at Lina Diabetes and at SL Raheja Fortis Mahim. He is also awarded the RSSDI Fellowship for the year 2017 and Fellowship of the Royal College of Physicians of Edinburgh for the year 2019. He is the PI in various global MNC clinical trials and devices and the Technology Task Force member RSSDI. He has written more than 25 papers in national and international journals. So without further ado, Sir will be speaking on interchangeable glargine.
Thank you, Nikhil and Chairperson, sir, and warm good evening to all of you. My disclosure is that I'm contracted for this conversation, that I'm speaking on interchangeable glargine, translating evidence into benefits. So this is supported by Biocon in favor of the evidence for their glargine, which now has an interchangeability label to that. So let's start with understanding that Biocon's insulin glargine approval, they've already gotten that across the globe in major markets, and in India they got the approval in 2009. Now, when you talk about the interchangeable data package, I'm going to take you through what really has given them this label and the studies behind what they've conducted. So it's essentially the first one for approval was the global PKPD phase 1 study, which was their Biocon's glargine versus European Union Lantus versus European Union versus US Lantus. And then they have the InStride 1, 2 and 3 data, which I shall be describing in detail. So the global trials for Biocon's insulin glargine have been spread across the globe, done in many parts of the world, and obviously hence they've gotten approval in various markets, including the US, Japan, India, and many other countries across the globe. So we look at the global phase 1 PKPD data, which they had released the abstract at the ADA San Diego in 2017, which was comparative pharmacokinetics and pharmacodynamics of a proposed biosimilar glargine as compared to the reference insulin glargine, which has been the Sanofi glargine, of course, in patients with type 1 diabetes. It was a PKPD bioequivalence study, about 114 type 1 diabetes patients, single center randomized double-blind, single dose, 3-way crossover, hyperinsulinemic euglycemic clamp study where patients received a single subcute injection of 0.4 units per kilogram of each of the trial drug. And this is the phase 1 study design. As you can see, there were 3 comparators, which was, when I say the Biocon, this was also co-made by Mylan, and hence the name you can appreciate, MYL1501D. So that versus the US glargine and the European glargine. At each clamp, then there was a 3-way crossover, so each of these patients getting in the benefit of the other drug. And this again, because it's funny, but the US will not accept the European Union glargine as the reference one, and European Union will not accept the US glargine as the reference one, and hence you had to have both of these as comparators to get the data. You look at the pharmacokinetic comparison, you will see the PK profile, which is overlapping on each other. So you can see the mean insulin profile, no difference, similar insulin concentration profiles for all the 3 insulin glargines which were used here. You look at the plasma M1 profile, which is the metabolite. So glargine after subcutaneous injection undergoes an enzymatic degradation into its metabolites, M1, M2. So you look at the plasma M1 profile, again you see them as similar concentration profiles. You then look at the pharmacodynamic data, which is where you start looking at the glucose infusion rates. And again, the glucose infusion rates profiles were nearly superimposed for all the 3 glargines used in the study. So the conclusion of the phase 1 study was bioequivalence of the biosimilar insulin glargine, the US insulin glargine and the European glargine was demonstrated in patients with type 1 diabetes for both the primary PK and the pharmacodynamic endpoints. Biosimilar IG, US glargine and European glargine were generally well tolerated and no significant safety issues emerged in this phase 1 study. We moved to look at the data from INSTRIDE 1, which was a non-inferiority study to compare the efficacy and safety of Biocon's glargine with reference insulin glargine again in type 1 diabetes. The objective was whether the Biocon glargine once daily is non-inferior again to the reference glargine. Multi-center this time, open label, randomized, parallel group, phase 3 comparative study, 550 at type 1 patients, A1C less than 9.5 at screening, and they were treated with once daily glargine for at least 3 months before entering the study. That was the inclusion criteria. You can see the screen in 4 weeks, run in 6 weeks, and then randomize 1:1 arm either to Biocon's insulin or the reference insulin glargine, which was Sanofi's, and then a follow-up safety period for 4 weeks after this. The primary endpoint was to look at the change in A1C from baseline to week 24, and you had the non-inferiority margins defined as staying under 0.5%, so 95% confidence interval staying below 0.4%. Secondary endpoints again, A1C, change in fasting glucose, insulin dose, and SMBG data, and some other safety secondary endpoints looking at hypoglycemia and immunogenicity. So you look again the data for the actual HbA1c and the fasting plasma glucose by visit and treatment, and you're able to appreciate that the A1C stabilized at all time points from the baseline, and you're able to appreciate that here at each study visit you're seeing superimposed lines between the Biocon glargine and the reference glargine. And the actual fasting plasma glucose also did not differ and was similar at all the patient visits. So the INSTRIDE 1 concluded again that the LS mean difference, which is the statistical way of looking for these differences in the studies, between both these insulins was similar at weeks 24 and 32, no statistically significant difference in the actual A1C profiles. Both basal and bolus insulin levels did not differ. So in terms of insulin requirements did not differ in the groups. Rates of hypoglycemia and other adverse events were comparable between the two groups. The INSTRIDE 2 was a study which was again a similar study, but this time done in patients with type 2 diabetes. You had about 560 type 2 diabetes patients who were at least had diabetes for 1 year, and they were on stable dose of oral anti-diabetic drugs for 3 months before screening. The study design, similar screening period of 4 weeks, randomization 1:1 arm to biosimilar insulin glargine or the reference insulin glargine, and then a follow-up period of 4 weeks from the safety aspect. Similar study endpoint, change in HbA1c being the primary endpoint, non-inferiority again defined similarly at 95% confidence interval staying below 0.4% at week 24, and the secondary efficacy and safety endpoints as mentioned earlier for INSTRIDE 1. The data, you look at the INSTRIDE 2 data, mean actual HbA1c over time, you again see no difference between the Biocon's glargine and the reference glargine across the visits here. So mean change in A1C, 0.6, 0.66 in the reference glargine, and clearly, as we said, this was way below the minimum requirement for non-inferiority, proving the non-inferiority of the biosimilar glargine to reference glargine. Mean actual glargine dose over time, again, you don't see any difference whether this being in the overall patients or those who were insulin naive. In terms of the dose requirement between both these groups was no different in comparison between both the studies. So the INSTRIDE 2 again concluded that mean change in A1C from baseline to week 24 was 0.6% for glargine and 0.66 for Biocon's glargine. Results demonstrated biosimilar insulin glargine is non-inferior to reference insulin glargine. Change in fasting was similar. Rates of hypoglycemia and other adverse events were comparable between the two groups. Then we look at the INSTRIDE 3 data, which was to again assess the efficacy, insulin dose, safety and immunogenicity in people with type 1 diabetes, which had a switch between the Biocon's insulin glargine and reference insulin glargine. So this study design was very unique in the sense you had patients who had in two different arms. One remained in reference insulin glargine and Lispro, which was the non-switching one, and the other one, sorry, And the other one was where patients were on Biocon's insulin glargine plus Lispro in the first period of 12 weeks, switched over to reference glargine, which is Sanofi's, plus Lispro, and again after 12 weeks going back to Biocon's insulin glargine and Lispro. So this was an interesting study design, the INSTRIDE 3, followed by the follow-up visits. You look at change in HbA1c from baseline to week 36, and change in A1c from baseline to week 36 with Biocon's insulin glargine was equivalent to reference insulin glargine. So you look at the endpoint, which was week 36, and you see any non-significant difference between both the HbA1cs at end of 36 weeks. Importantly, you're looking at safety endpoints. Anytime hypoglycemia, overall incidences of hypoglycemia were comparable. No severe hypoglycemic events occurred at any time point in the study. So again, the hypoglycemia safety data was comparable. Importantly, they were looking at immunogenicity data here. So cross-reactive antibody, insulin antibody percentage binding over the treatment time was again found to be similar. No difference in immunogenicity between both these insulins. You also had data looking further at immunogenicity from both INSTRIDE 1 and 2 studies, and this was found to be comparable. So no statistically significant changes from baseline in the cross-reactive anti-drug antibody percent between both the comparators here. Proportion of patients with total cross-reactive insulin antibody response. Again, proportion of patients who met the criteria for cross-reactive anti-drug antibody or total anti-drug antibody positive response was similar in both the groups. You don't see much of that in type 2 patients, very, very small numbers, but type 1 patients do have some immunogenicity, but it was comparable in both the groups for reference glargine and Biocon's glargine. So the conclusion from the immunogenicity assessment again was comparable immunogenicity. Majority of patients with type 2 diabetes were negative for total anti-drug antibodies. Majority of patients with type 1 were positive, but it was similar in both the groups. Proportion of patients who tested positive for the anti-human cell protein antibodies, which is another aspect of looking at immunogenicity, was similar between the treatment groups. So let me summarize by saying that Biocon's glargine has gotten the world's first interchangeable biosimilar insulin label. It of course is made in India and it's for the world, so it goes with our PM's call. For patient benefits, what we want to offer them is high quality insulins at better affordable prices, which ensures early initiation and adherence to insulin therapy, which is the larger message out here, that let's offer the benefit of insulin to our patients. From the healthcare practitioner's objective, they have options to provide quality insulins today and more affordable insulins to their patients, reduce probably the overall economic burden, ensuring better compliance to therapy. So with that, I end my presentation and hand it back to the chair for any questions before I rush off and give the session to Neeta.
Thank you very much. If anyone has questions, I think we'll take after this session. I call upon Madam Dr. Neeta Deshpande. Dr. Neeta has her own diabetes center in Belgaum, Children's Diabetes Center. She is Professor in HOD MM Dental College, Associate Professor of Medicine, KLE International Medical Program, MD FRCP, Edinburgh, PG, Endocrinology, London, a special certificate on obesity from the USA. She has several presentations on obesity, diabetes in international and national meetings, published in publications in peer-reviewed journals, textbooks, past chairman of RSSDI Karnataka branch. She has KRSSDI Origin 2016, fellowship in RSSDI 2016, and member expert committee RSSDI 2017 consensus guidelines. I call upon Madam Deshpande now to take us into clinical aspect of basal insulin, a pragmatic approach.
Thank you very much, chairpersons. I'm grateful to all of you for still being here at this time of the evening when everything is coming to an end. The talk that I'm giving today has been supported by Biocon. That's my disclosure. But the talk is going to be more general. It's going to be more about how we initiate insulin, what are the factors that prevent insulin being initiated, and also how best we can titrate. So these are some of the practical aspects that I'm going to discuss today, because this is what we face in everyday practice. Every day we are faced with patients in whom insulin needs to be initiated. We talk to them about it. Sometimes we do not have the time to talk to them about it. and insulin is not initiated, and that is the reason that this talk is being talked about. So I was talking to you about insulin not being initiated when it actually needs to, and this is a very telling study, very good data to talk to you about the clinical inertia that is seen for patients with type 2 diabetes, when you need to give insulin but it's not being given. All of us talk in conferences about glycemic, the metabolic legacy, the legacy effect, the glycemic burden that should not go on for too many years, but in reality this is what you see. And what you see here is that a person who is on 1 OAD and has an A1C more than 7, the median time to actual intensification is 2.9 years. So you've lost 3 years there. Somebody who is on 2 drugs and has an A1C more than 7%, it could be as high as 7.2 years before insulin is given to that person. And if you look at the actual A1C at initiation of insulin in people with 1 oral drug or 2 oral drugs, it is 8.7% and 9.1% respectively. That means that you have waited for whatever reason till the A1C has reached rather an unacceptable point and has remained so for 3 years or 7 years or 8 years, and the median time to intensification you can see here was 7.1 and 6.1 years. This brings home to you the point of the extent of clinical inertia, which can be very, very detrimental to the patient in terms of future life and complications. So when do you recognize now that basal insulin is not enough? What I mean to say is, you have initiated insulin with basal insulin perhaps, but oftentimes both on the side of the patient and on the side of the doctor, the fact that insulin has been initiated is often thought to be enough. No one thinks about the titration part. But starting insulin is only the first step in a progressive event profile, which means to say that the job is not done by just initiating insulin. You need to titrate it and treat to target, and only then have you achieved something for the patient. So when do you actually realize that basal insulin has been started, initiated, but it's not enough? That you recognize if you correctly monitor the patient and you find that there's a persistently elevated postprandial above 180 or the A1C is above target. That's when you want to start something else other than just basal. Or a type 2 diabetes patient requires more than 0.5 units per kg. It means that there is a reason to start actually a mealtime insulin. Or you keep on increasing the basal and then you find that the patient has nighttime hypoglycemia. You know that you need to go beyond basal insulin. And when to stop titrating basal insulin. You're giving basal insulin and you keep on increasing the dose, and it's a single insulin, but then you need to stop that sometime if you find that things are not going the way they should. As I said again, the HbA1c is not at goal and the basal insulin is high, and you have a normal fasting and yet the A1C is elevated. So obviously the contribution to that A1C is coming from somewhere else, and that's the postprandial. And you also see that the postprandial is persistently above goal, and you are getting hypoglycemia because of repeated increases in the dosage of basal insulin. So this is the concept of basal intensification. What it says here is that you give lifestyle changes, metformin, other agents. Now there is a lot of thrust on the ominous octet, and because of which you give combination therapy right at the beginning of oral drugs. Be that as it may, you have given all of that, but it's not to goal. There is progressive deterioration of beta cell function, as you know. Then you add basal insulin, you titrate it, and then you find all the reasons that I showed you in the previous slides, that the A1C is not at goal, the hypoglycemia rates are high, or the basal insulin dosage is hitting more than 0.5 units per kg. That's the time to add prandial insulin with the main meal. So that is basal plus. So basal plus is something you need to understand, is a transition between just basal insulin to full basal bolus therapy. And this transition could last for quite some time. It could last a long time, and that's the scientific way to do it. And once you find that basal plus is not enough, then you will go to basal bolus. So the ideal subjects for basal plus therapy, that means you have started basal and you just want to give one more dose, which is given prandially. Ideally, you should give it to people who are on basal and oral agents and have an A1C between 7 and 8. So they're not too bad, but they're not at goal. So you start with giving just one more, or patients are treated with 2 or 3 oral agents and have an A1C more than 8.5, or patients on basal plus oral with an A1C more than 8 and who do not want to go all the way to basal bolus, that means 4 injections. So as I said, this is a transition therapy. So you have all these kind of patients. What you see on the left side are situations that you are seeing every single day in your clinics. And these are pointers to you that this is the time that I actually need to add one prandial dose, or patients who are starting corticosteroid therapy. So this is how you look at the regimens, what will suit. You know, we are living in an era of designer treatment, designer therapies, designer insulins, and this is how you compute how you're going to do that. So this is the approach now to the basal plus intensification. So a fixed single bolus dose of 4 to 6 units administered with the largest meal of the day. How do you do it? How do you decide which meal, or where do you give that basal plus, that second dose? So you can actually keep on checking the glucose, ask the patient to come back with the reports with self-monitoring, find out where he is spiking. So the highest spike that you are seeing, that's the time that you give the prandial dose, or simply defined by the postprandial blood glucose. Or you can do it based on a previous basal dose. You give 10% of the basal dose, or based on the patient's weight. There are various ways in which you can do it, but see what suits you best and what is most practical. And this is what the ADA 2021 recommends: intensifying with basal plus regimen, addition of 1 insulin injection before the largest meal. And that is logical, and that is practical and reasonable to do so, because you want to bring down that spike, and bringing down that just one spike might normalize everything if you are not able to achieve your goals with basal insulin alone. This again is the ACE 2020 guidelines, and these are really very good. They ask you to start basal if the A1C is less than 8 at a smaller dose and more than 8 at a slightly larger dose, and the titration algorithm is given to you. And if the patient is not at goal, there is a chance that you might add a GLP-1 receptor agonist, or maybe an Sglt2 or DPP4 if it hadn't been added in the first place. Then you can add that, and yet if the patient is not at goal, then you add the prandial insulin. You add one first, then you can add the second, and then you can go all the way and make it a complete basal bolus therapy. So this is done with titration. Please remember, as I said much earlier, that titration is the key when anybody is on insulin. It's not like you give insulin and forget about it, and that is why most people stop taking insulin on their own, only because the titration is not done and they feel that insulin is not acting upon them. So as I said, titration is an important component of therapy. These are the RSSDI guidelines, which are very similar to the guidelines that I've already shown you, where you initiate with basal based on the A1C, less than 8, more than 8, the dosage is different. Titrate every 2 to 3 days to achieve glycemic goals, and you can add based on this algorithm 4 units, 2 units, or 1 unit. And of course, you need to monitor for hypoglycemia and down titrate as and when required. So this is the insulin glargine titration on talking about till you reach your target. So it is treat to target. Now this is some clinical evidence to show you the difference between initiating with glargine or a premixed insulin. And you can see here that whether it is efficacy in terms of HbA1c or in terms of adverse events, hypoglycemia, you can see that it is always wiser to start with a basal insulin over and above the oral drugs rather than giving twice daily premix, because you stand the chance of hypoglycemia. So beyond basal insulin, when treatment is intensified, you have to take several things into account. Number one is patient preference, what he would like. The second is the safety and tolerability. The third is the efficacy, because ultimately your targets are important, because the complication rates are going to be dependent upon the targets achieved, and the risk of hypoglycemia and other non-glycemic effects such as weight change in lifestyle. I told you they are designer insulin, it cannot interfere with a person's lifestyle. So the last slide that I'm going to show you and leave you with is the most practical slide, I would say. That is, how do you actually bring insulin initiation into the conversation with the patient? We all know that the minute we say insulin, the patient shuts his mind off, doesn't listen to anything else that you are going to say, and you may have lost the battle. But you have to try, and we know that we have to overcome all these barriers, and there are strategies for that. First and foremost, it's the needle phobia. So you will have to show them how the needles are so fine nowadays, and you demonstrate the technique and have someone give the patient an injection, have him take it himself. And there are many doctors I know, I'm not that brave, but there are many doctors I know who actually inject on themselves and show it to the patient. But as I said, I'm not so brave. But if you're up to it, you can try that as well. The second is you can get help from certified diabetes educators, dietitians. You can train your own dietitians. You can consider clubbing 3 or 4 patients together and showing it to them, because there's always safety and some kind of identity in 3, 4. The overemphasized, it has changed therapy completely, and once patients see a pen, they find it very, very easy. They think that, okay, this is easy to transport. I don't have to carry a vial, a syringe, the other paraphernalia that is there, and so they're very, very happy about that, and they may accept it immediately. If you have a pen on your table when you're practicing and just show it to them, show them the needle, which they cannot even see sometimes with the naked eye, and they're sold, and they actually go for it. You keep it simple. You begin it with basal insulin. It is simplest. It's not just because it's in the guidelines, mind you. It is very easy to start a patient on basal insulin because the hypos are less, the weight gain is less. It's easy for the patient. It is without regard to time of the meal, even if the patient has gone out, so even it fits in with the lifestyle. So it makes it very, very flexible for the patient. That, okay, I can do what I want all day. I'll take my drugs as usual. I'll come back home at night and I will inject. So what happens is, when you make it easy for the patient and his lifestyle, then, because there are a lot of myths, there are a lot of people telling them, oh, you need to do this before meal, you need to do it after meal, and then the patient worries about his own lifestyle. The fear of hypoglycemia is something that we as doctors are responsible for training a patient for hypoglycemia, recognizing it, making it sound simple, making it easy for himself to treat, and that's entirely our responsibility. Weight gain, of course, exercise and dietary advice before initiation of insulin has to be given. The patient has to be told what he needs to do in terms of lifestyle modification so that he minimizes his need for insulin as well. You can show him the needles, as I said, they're really, really small nowadays, and the patient is very, very happy to see that, and you can actually kill one of the barriers of needle phobia just by showing it to the patient. Now, practically speaking, the other thing that I do for my type 2 diabetes patients is I literally tell them that my young type 1 diabetic patients of 10 years, 12 years, 14 years, if they can inject themselves 4 times a day in the school, on the playground, why are you shying away from this? Once they hear that, they are kind of convinced that yes, if a child can do it, if a 12-year-old can do it, why can't I? So that is how you will have your own metaphors and examples to give, but one needs to go that extra mile to convince the patient. It's not like, lena hai to it's your life. If you want to take it, take it. I don't have the time. It's not like that. That's a human being in front of us. Imagine if you were told to take insulin, what would be your reaction? And that empathy is required even for the patient. And that is the key. And that will make you explain to the patient why he needs to take insulin. So I'll leave you with that slightly philosophical thought. And I'll be glad to take any questions. Thank you.
Thank you, ma'am, for such an easy to understand and practical approach to glargine. If the audience has any questions regarding the last talk.
AM and PM? Okay, yeah, giving it. It varies individually. On an average, it should not make a difference what time of the day you give it, as long as you give it every day at the same time. It really doesn't make a difference. But having said that, there are individual patients in whom the pharmacokinetics is such that it does not last the entire 24 hours. And if it does not last the entire 24 hours, the fasting which you're looking to target, you may not achieve that target, and then you might have to shift it to the night if the morning insulin does not do it. As far as GLP-1 receptor agonist is concerned, it does not matter at what time of the day you give it. It has absolutely no bearing whether you give it before the insulin, after the insulin, not at all. It makes no difference.
Any other questions? All right. So thank you so much, ma'am. We will continue with the next session.
Yeah.
Thank you, audience, for being here.
Thank you very much. Now let's go to the next session, and I call chairpersons Dr. Amy Sanghvi, consultant diabetologist and co-director Sanghvi Eye Center, Mumbai, and Dr. Deepak Chudasma, consultant diabetologist, Hope Diabetes Center, Junagadh. Thank you.
Yes, good evening to all. Moving forward to our last session of day today, I am inviting Dr. Nandita Arun for next talk. She is consultant diabetologist in A. Ramchandra Diabetes Hospital, Chennai. She has various fellowship degrees from Glasgow and UK. She has been awarded with COVID Warrior in COVID pandemic. She is Diabetes Care Personality of the Year 2019, Outstanding Young Investigator Award, and also she received RSSDI Young Investigator Award as well. Above all, she is my teacher and PG guide. Over to you, ma'am. Thank you.
Thank you, Deepak, and thank you, Ami, for chairing the session. Yes, it's an absolute pleasure when you see, I wouldn't want to call you my student, but yeah, maybe if I could say so, chairing your own session. It's an absolute pleasure, really. So, very good evening, everyone, and I bring greetings from ARH Chennai. Of course, I would like to thank the organizers before I start for inviting me, and very happy to be part of Diabetes India 2022. The topic that I'm going to be discussing today is sort of an extension of what we've listened to in the last couple of sessions from Dr. Neeta, from Dr. Manoj, where they addressed inertia or clinical inertia in the management of diabetes, and that's what I'm going to be discussing further in general today, not just specifically for insulin, but in general as such. So I'm going to start off because at the end of the day, we're all here, we are all clinicians, and when we leave the hall today, I want us all to be able to apply this and take a carry home message to our clinics when we get back on Monday morning. So I want to start off with a clinical scenario. This is a Mrs. So-and-so who is 47-year-old, who is a homemaker, mother of 3 children, and she's been newly detected with type 2 diabetes. She's now sitting in the clinic with a HbA1c of 7.1, fasting of 128, postprandial of 189, and she has no comorbidities or complications at the moment in this consultation. So after discussion with the patient is hesitant, and this is very common, isn't it? How often do we find patients saying, no doctor, do I need to start off on medication now? Start medicines, will I have to take it lifelong, isn't it? This is a question that most patients come up with. So this patient, not so uncommon, she was hesitant to start medication, and so she was advised with lifestyle modification only and advised to review after 3 months. But of course the story didn't end there. She comes back only 3 years later, and this time she comes with complaints of weight loss, and her HbA1c from around 7 that it was has now spiked up to 9.1, and at this point now she already has 2 complications, retinopathy and microalbuminuria has already set in. So what went wrong here? Was this absolutely avoidable, and who is responsible here? That's what we are going to be discussing here today. And this is exactly what is called therapeutic inertia. The definition of this is the failure to establish appropriate targets or to escalate therapy in order to achieve those targets. And therapeutic inertia is what is most of the time responsible for the complications which are most of the time preventable in patients with type 2 diabetes, with diabetes in general. And having said that, this is what brings us to the concept of the so-called glycemic burden. So here you see, don't know if my pointer is going to show up on the screen. Yes, it is, great. So typically when we see the patient for the first time, we find the first HbA1c is below goal, and we are okay with that. In the next visit, the HbA1c subsequently then goes up, and then we don't act, take no action for whatever reason that might be. Next visit it further goes up, and this is the story that's usually happening. And this over here, the threshold above which the HbA1c then spikes up is what is called the glycemic burden, which is what is responsible for our increased risk of complications in our patients. And this is typically what we find in our in probably most patient scenarios, where we have the so-called stepwise approach, where initially, just like the patient that we saw in our first case study, we initially advise the patient on just lifestyle management, and then we wait until the next visit till the HbA1c goes up, and then we add one agent. Then we wait until the HbA1c goes up, and then add the next agent. So every time we are actually reacting to a high blood glucose. Instead of being proactive, we each time wait for that HbA1c to go up, and then we take action. And in the meantime, the patient is being exposed to that amount of hyperglycemia and the so-called glycemic burden, which in turn is not going to give us very good outcomes. And we know that the best way to reduce the risk of complications, of course these are the landmark trials, I don't need to dwell too much on this slide, but we do know the take-home messages from these slides are that trials like the UK-PDS, which is the landmark trial that showed us that in fact it is intensive glycemic control and early glycemic control that can reduce the risk of complications. We know that early intensive glycemic control will reduce the risk of microvascular complications, but when it came to the macrovascular complications, even trials like the ADVANCE, the ACCORD and the VADT failed to show benefit in terms of macrovascular. However, the UK-PDS did show benefit in terms of macrovascular risk reduction only in the long-term post-trial follow-up, the so-called legacy effect, isn't it? Now, this legacy effect is what we learned from the UK-PDS. But in a publication by Dr. Kamlesh Kunti et al., this is what they have termed as dysglycemic legacy. So from the UK-PDS, we learned about the legacy effect. But here we are going, the legacy effect in terms of glycemic effect. But here we are going to talk about dysglycemic effect or the dysglycemic legacy. So what is that? In this study, which was very interestingly conducted, what was done was patients who were newly detected with type 2 diabetes received intensification of therapy within the first 1 year versus patients who did not receive intensification, in other words, did not maintain in the first 1 year HbA1c of less than 7%. So only for that first 1 year, the patients with intensive therapy versus non-intensive with less than 7% HbA1c. And at the end of 5 years, they actually found that there was a significant increase in cardiovascular outcome in the control arm, with a 67% increase in MI, 50% increase in stroke, 64% increase in heart failure. So high cardiovascular burden when treatment intensification is delayed in the first 1 year after diagnosis. Now, how is the burden of diabetes in our country? I have to touch upon a little bit of epidemiology here. Do we think, yes, we all know that we have explosions of type 2 diabetes in our country. We know that there are large growing numbers of patients with type 2 diabetes, but are the numbers still growing? The answer is yes, absolutely. So here we have data that from our center that we've been publishing right from the 1980s. And we've been going back serially almost every decade to look at the prevalence of type 2 diabetes, not just in the urban, but also in rural India. And as you can see, the arrow is actually going upwards and we have exploding numbers. What are we doing about this is the question, right? At the same time, the drugs for the management of type 2 diabetes, we can't complain because we are in an era where we have also an explosion of drugs. Look at the evolution of management of type 2 diabetes. So with the evolution, you first had insulin, which was discovered 100 years ago, and then there was sulfonylurea, and then there was a lull, a period where there was no other agent that was available until metformin came back in 1990s. And then look at this spike in the number of agents that we have today. So we as clinicians treating patients with type 2 diabetes should not be complaining, especially in this era where we have at our disposal n number of agents to choose from, agents that are powerful to reduce the HbA1c, agents that are powerful to reduce the HbA1c without the risk of hypoglycemia, agents that offer benefit with not just reducing HbA1c but beyond glycemic benefit in terms of reducing the risk of complications. The Sglt2 inhibitors, the GLP-1 receptor agonists. So we literally do not have anything to, no excuse to not be achieving targets. However, this is data from Gare et al., which shows that among the multidisciplinary approach that we have, or the ABC, that is the A1C, cholesterol and blood pressure, still, this is data from 2003, a long time ago, but where they showed that the target which is the most challenging to achieve is HbA1c. Among blood pressure, cholesterol, you can see almost 70% of patients, and this is true in our daily practice, we see this every day, isn't it? It's quite simple to control that cholesterol, quite simple to control the blood pressure, but somehow when it comes to blood glucose, it is very challenging. And let's look at data. This is global data. This is the percentage of patients who are not achieving targets, and it's quite, this is good news that we have here, that we are not doing that bad, so we should probably give ourselves, pat ourselves on our backs. Maybe conferences like this are really helping, where 50% of our patients are achieving a target less than 7% compared to high numbers like 80% in Algeria, almost 80% in Saudi Arabia, 75% in Malaysia, patients who are not. So merely hardly around 20% of their patients and 50% of our patients. But what about that 50% who are not achieving targets, right? This is a very interesting publication in which our center was a part of, in which it was a global study where it was a multidisciplinary, multi-center sort of model, in which what was looked at was the trend in prescriptions and trend in approach to type 2 diabetes management over the years. Is there a change in our trend of prescriptions over the years from 2006 versus 2015, over a decade? Because now we have so many agents, have our patterns of prescriptions also been changing? And this is the results of the study. And this is data that you have from India, which I've highlighted here. And if you look at comparing 2006 versus 2015 over a period of 10 years, yes, we are improving. If you see the red bars, there is an intensification in terms of increase in insulin therapy, and we are treating with more aggressive triple drug therapy as compared to 2005, and our monotherapy and diet only has actually come down. So we are actually trying our best as physicians to intensify. We are intensifying our approach. And in the bottom over here, you see the change in HbA1c when we compare India to other countries like South Africa, where there has been from 2000, over a period of one decade, there's actually an increase in the HbA1c of patients with type 2 diabetes, whereas in India, there's actually a significant reduction in HbA1c levels over a period of 10 years. And these are the patterns of prescriptions. So if you compared 2006 versus 2016, the percentage of of course, Sglt2 inhibitors were not available then, but 16% prescriptions of Sglt2 inhibitors, this is the percentage of increase. 20% with meglitinides, alpha glucosidase 22%, and 2.8% of GLP-1. So we are actually underutilizing the GLP-1 as compared to a whopping 10% in Australia. But compared to Hong Kong, we're doing much better. So we're prescribing GLP-1 receptor RAs quite well, I'd say. 40% of our patients are on DPP-4s, 77% of our patients on sulfonylurea, and metformin increase seems to have increased from 60% to around 90% of our patients are on metformin, which means that we're actually doing pretty well. So our patterns of prescriptions have changed, and we are definitely trying our best to intensify therapy, but is it good enough is the question. So where is the root of the problem? When it comes to therapeutic inertia, where is the problem actually? There are several reasons, and it can be either clinician related, patient related, or the healthcare system related. Clinician related the reasons would be insufficient time, isn't it? And just like Dr. Neeta was just saying, we are all so busy in our practice, we don't sometimes see the patient as another person, and when the patient is hesitant to start medication, we sometimes just dismiss it and say, because we need to see the next, we have a whole number of patients waiting outside, so we really don't have the time to spend that much, isn't it? The next is the patient hijacks clinical visits, and this is something similar to what we saw in our case study, where patients themselves are hesitant, and they sort of take over the consultation and say, doctor, don't worry, I will show you next time, isn't it? Next time I will bring down my HbA1c, don't worry doctor, leave it to me, I will take care, isn't it? It's because I had some weddings, I took some sweets, my granddaughter's birthday party, or whatever it is, there's always an excuse. So this could be one of the reasons, and many a times we also don't want to lose the patient. When it comes to treatment intensification, if we enforce, and if we are forcing patients when they are not willing, sometimes the patient might just go to the next doctor, isn't it? So that itself is one of the reasons why many clinicians, I think, just don't want to be too harsh, or they're just the fear of losing the patient itself. And then, of course, the reactive instead of the proactive approach, which I already addressed. The patient-related reasons would be denial of the disease, lack of health literacy, medication-related, very, very important, where side effects of medication, too complex regimes where we give them multiple shots of insulin per day, or multiple tablets, or the pill burden is too high, or costly medication in our part of the world especially. And last but not the least, and this is something that's very, very important, absence of symptoms. We must remember that diabetes, especially type 2 diabetes or hyperglycemia, can be asymptomatic, and we all know that. So for the patient sitting in front of us, taking that shot of insulin or taking that oral agent is not rewarding. When the patient has a headache, he's anyway going to take in that paracetamol, or if he has a tooth pain or whatever, or a stomach pain, he's going to take that tablet. Even for blood pressure, sometimes they're symptomatic and they say, oh, I have a headache, maybe my blood pressure is high, and they take in the tablet. But when it comes to anti-diabetic agents, taking their medication is not rewarding. So what keeps the patient motivated, chronic, for their entire lifetime to take their medication? Isn't it? This is something that we need to think about, and probably spend time explaining to our patients the importance of adherence to their prescriptions. And then, of course, the healthcare system could also be something that may be a reason for it, where we don't have supportive staff, we do not have patient educators, nurses, and so on. So the solutions to therapeutic inertia would be to have, as far as possible, to find solutions to those problems that I just discussed. Maybe try to spend more time with your patients. If you do not have the time, invest in a patient educator or a nurse, or just someone who can explain to your patients and spend some time clearing their doubts. For patients who have fear of injections, maybe improved devices. All these are various approaches, and a psychologist, or basically an integrated approach that could actually help with overcoming therapeutic inertia. And last but not the least is, of course, apps and mobile technology, or the application of technology in diabetes. And there's a big boom, of course, we know. With all the apps, there's been some discussions even today in some of the sessions about mobile apps and their roles in improving patient outcomes. So we had actually, I'm just going to end with this last part of my talk, which is one of the studies that we had actually conducted to actually look at the role of improving adherence to prescriptions through simple mobile phone text messages. So patients who were newly detected with type 2 diabetes, around 250 patients, were randomized into two groups. Both the groups received standard of care, but only one group, the patients received serial text messages on their phone, just basically reminding the patient to adhere to their prescriptions and to take their medication regularly. Just simple text messages in the local language or in English, twice or thrice a week, to remind the patient. And at the end of the study, we found that there was a significant improvement in HbA1c in the intervention arm, that is the SMS arm, as compared to the control arm, and a significant improvement in the fasting plasma glucose in the intervention arm. So simple text messages on the mobile phones actually helped in improving patient adherence and in turn improving outcomes in these patients. So in summary, we do have a huge burden of type 2 diabetes, especially in our part of the world, and not just in the urban but also in the rural areas. And we have, in spite of so many newer agents that we have available, and in spite of our trends in prescriptions, we of course are trying our best to intensify therapy, but somehow we have to identify what is going wrong, identify where the inertia is actually existing, think about the fact that the whole dysglycemic legacy is also equally important, and early intensive control is extremely crucial to reduce the risk of complications. Simple solutions like maybe having a patient educator, patient education programs, improved devices, and like I showed you, the role of technology also could go a long way in combating therapeutic inertia and thus improving outcomes in our patients. Thank you.
Thank you, Dr. Nandita, for such a wonderful presentation. If we have any questions, we can take a couple of them for ma'am. Yeah.
Absolutely. Yes. Thank you for that.
Thank you, sir. Any more? Okay. Thank you, Dr. Nandita. Thank you for a wonderful presentation. Moving on to the next talk of this part of the symposium, Mixed Bag. I invite Dr. Om Lakhani, who is going to be taking us on the mechanism of beta cell dysfunction in type 2 diabetes. He's a well-known endocrinologist from Ahmedabad, the winner of the President NBA gold medal in endocrinology, second runner-up in AV Gandhi Award 2017, winner of 2 gold medals in MD, winner of 5 gold medals in MBBS, winner of API Dr. Vittal Rao Nadgowda for best thesis in MD medicine, and the developer of the notes in endocrinology, and one of the most famous speakers we have around. I invite Dr. Om Lakhani to take over.
you so much, ma'am, for the kind introduction. And sorry for the delay. I think the slides were taking a time to get loaded. Thank you to the organizers of Diabetes India for having me. Such a wonderful venue, and I think I'm sitting right in between, maybe an enjoyable dinner, maybe some fun. So I'm going to talk to you about mechanism of beta cell dysfunction in patients with type 2 diabetes mellitus. So, we always learn a lot from our animal models, right? And what have we learned from our animal model of diabetes? Let me take a step back. What's the difference between a pre-diabetic and a patient with type 2 diabetes? The difference really lies in the function of the beta cell, right? A pre-diabetic is perhaps as insulin resistant as a type 2 diabetic, but a type 2 diabetic, the beta cell does not function as well as a patient with pre-diabetes. So this is what we have learned from our animal models. So what they do when they create models for type 2 diabetes, animal models, they remove certain hypothalamic regions of these mice, and these mice are given unlimited food. So it's like this, right? There is unlimited food for you, and you have absolutely no satiety. So you can eat as much as you want. The mouse keeps gaining weight, and then what happens, right? The interesting thing is that the mice keep gaining weight, keep becoming more and more and more insulin resistant, but some mice develop diabetes, whereas others do not. Why? So what's the difference between a mice who develops diabetes versus a mice which does not? Well, the mice who develops diabetes has poor beta cell function. At some point of time, the beta cell function is not able to catch up with the insulin resistance, and that is type 2 diabetes. And that is exactly what happens in patients with type 2 diabetes in clinical practice. So, obesity increases insulin resistance, or any other factor increases insulin resistance, but if the insulin production is not able to match up with the insulin resistance, that is when diabetes develops. Let me put a corollary to you. There are a lot of patients who are obese, but they're not diabetic. And there are a lot of patients who are not obese, and yet they're diabetic, right? So if obesity alone or insulin resistance alone led to diabetes, every obese person should be diabetic, but that's not the case. Secondly, let me tell you another interesting thing, right? And we'll come to this point in a minute, right? So, this is a sort of a summary of how patients actually develop diabetes. And we know that insulin resistance keeps increasing but reaches a static point at a period of time. But what changes over a period of time is the beta cell function and the insulin levels. So initially, the body compensates by increasing the insulin production, but at some point of time, where you have the cutoff, where the patient stops, the beta cell stops working to the level it should, and that is when the downhill effect occurs, and that is when the patient develops diabetes, and then it continues to progress over a period of time. So at the time of diagnosis, 50% of the patient has lost 50% of the beta cell function, and they keep losing about 4 to 5% of the beta cell function every year. But the key question is, and this is the key point of today's discussion, and if you get this point, I think it's a job well done for me. The debate which is there in today's era of, as far as understanding of pathophysiology of diabetes is concerned, is that are we dealing with reduction of beta cell mass, or are we dealing with a reduction of beta cell function? This is the key question, right? Does the beta cell reduce in number, or does it become less functional? That's a key difference. Why this debate is important, right? There are arguments on debate on both the sides. If you talk about beta cell mass, and this is another very interesting paradox that you see. There are a lot of patients who undergo pancreatectomy, right? Partial pancreatectomy. Some parts of pancreas have been removed, yet they do not develop diabetes, right? This beta cell mass has been surgically reduced, yet they do not develop diabetes. Yet there are patients who are obese, who have increased beta cell mass, but they have diabetes. So what the debate which is of the two, which is winning, the side which is winning is actually beta cell function. So more and more we are realizing that it is not just the beta cell mass which is resulting in diabetes, it is probably a dysfunction in beta cell which is the problem. And why this debate is important in today's era? In today's world, we are talking about diabetes remission. And when I say that the beta cell mass is reduced, that means it is somewhat permanent, right? generally, if the cells die, they're not going to be resurrected, right? Well, they might be, we'll see, but generally they'll not. But if a beta cell stops functioning as well as it is, probably you can kick it and maybe it will start functioning better. So when I'm talking about a potentiality of diabetes remission, it is better to believe that beta cell function is the one which is causing diabetes and not the mass. And if the beta cell function can be restored, perhaps you can improve the outcome in diabetic patient. So this is why it is very, very important to understand the debate that if I'm saying that the beta cell mass is lost, that is perhaps permanent, and that means that there is perhaps nothing like a diabetes remission in true sense. Whereas if the problem is in beta cell function, perhaps there is a potentiality of diabetes remission, and that is what recent trials like DIRECT trial has shown. So why does the beta cell impairment occur in type 2 diabetes? Why does it occur? That's the and that's the key point of the talk today. What is the mechanism? What leads to the beta cell dysfunction? There are three key things, right? And this is a very interesting taken from a very interesting article, which are the models for beta cell impairment or beta cell dysfunction in patients with diabetes. So there are three major reasons. One is, of course, we discuss reduction in beta cell mass. We'll discuss this. The second key point, that is what again we are going to discuss, is the beta cell dysfunction. And the third and the emerging concept is that there is trans-differentiation of beta cells, right? Beta cells change into alpha cells or perhaps other pancreatic cells, and that is also perhaps leading to a problem in these patients, right? Why this is important? Because today's pathophysiology talk will perhaps be an option for treatment tomorrow, right? Today's understanding of pathophysiology is tomorrow's treatment, and that is what is really important. So the first model which we talked about is the reduction in beta cell mass, and what are the reasons for that? Now if you go back right from the beginning, there are a lot of people who say that people have, especially Indians, have low beta cell mass to begin with. That is fetal programming, Barker's hypothesis, Dr. Yajnik's things, right? The second is perhaps the beta cell undergoes apoptosis over a period of time, and perhaps aging itself leads to decrease in beta cell mass. So there is genuine reason that there could be reduction in beta cell, right, mass as well. About Barker's hypothesis. We know that perhaps there are epigenetic changes which occur in utero, and because of this there are certain genes which get switched off, and we are born unfortunately with a smaller beta cell mass that puts us at a risk of developing diabetes in future. The second model is the key one, which gives us a hope, right, that there are some factors which lead to damage or beta cell dysfunction, and there are two major reasons which have which causes this. One is what is known as endoplasmic reticulum stress, and second is what is known as oxidative stress. I'll discuss each of this. So what is endoplasmic reticular stress or ER stress? See, endoplasmic reticulum is given a task that it has to maintain a normal structure of the proteins, right? Now we know that protein is a primary, secondary, tertiary and a quaternary structure, and insulin is a very complex protein which has a very good quaternary structure, right? Now when a protein is formed, if this protein is not perfectly formed, the endoplasmic reticulum will destroy it. So when you have a lot of malformed protein accumulating into the endoplasmic reticulum, this produces a situation of ER stress, and in this situation the cells take a critical decision. I have a lot of garbage in my neighborhood, right? Now there are two things I can do. Either I can clean my neighborhood or I can close it down. A lot of COVID cases in my neighborhood, either I can treat those COVID cases or I can put a shutdown, right, or lockdown. So in lot of times the body tries to respond by by cleaning the system, but in lot of times when it is going beyond that particular system, the cells start undergoing apoptosis, and this happens not only in pancreatic beta cells, it occurs in many cells of the body, and that is very, very important. Second is the oxidative stress and beta cell dysfunction. Where have we seen this? We see this in patients who are having glucotoxicity. We have all seen, we see a patient who comes with blood sugar of 500. You start this patient on insulin, the blood sugar comes down, the patient's, endogenous insulin production improves, the C-peptide improves. Why does it happen? This happens because there is a system in our body where you have a chronic hyperglycemic state. It leads to increased reactive oxygen species, which stuns the pancreatic beta cells. The beta cells are not able to produce more insulin. This produces a vicious cycle, right? When the beta cell are stunned, there is no insulin. Less insulin means more blood sugar means more reactive oxygen species, right? So when you break this system, by giving insulin or by intensive management patient early on, you reduce the oxidative stress, improving the beta cell function. Again, this has very key importance in future in terms of pathogenetic treatment. The third model is, of course, transdifferentiation of beta cells. Beta cells start behaving like alpha cells. There is change in the nature of beta cells. This is still an emerging area of pathogenesis. We do not understand that, but somewhere, perhaps 10 years from now, if we come back at Diabetes India conference, hopefully at the same venue, perhaps we'll have some drug which prevents the beta cells from converting to alpha cells and perhaps going back to beta cell function. So of all these three models, the most important model is actually the model 2, the beta cell dysfunction, because at this point of time, that is the one which we can really treat and we can really help. Okay, so we had this debate on function versus mass, and at this point of time, there is nothing much we can do about the poor beta cell mass, but we can do a lot about the beta cell function, and that is what really we are looking at in terms of emerging treatment. So what is the clinical importance of what we have learned today, right? So few things. One is we have all seen this variant of Indian diabetes patient known as Indian Flatbush variant, right? Dr. Sujit Jha, unfortunately passed away a few weeks back. With all due respect to him, this is a beautiful article written by him. It was published in Diabetes Care, where he identified patients where, which was first identified in Flatbush, which is a region in Brooklyn, right? These patients come with severe hyperglycemia, obese patients coming with severe hyperglycemia, and when you treat this patient, they come with ketosis. When you treat this patient with insulin, suddenly after a few weeks, the insulin requirement goes away, they go into remission, right? This is a classical example of oxidative stress causing beta cell dysfunction, which is reversible. Of course, we have the key point is diabetes prevention also. This is a very important point. This is an article by Ralph DiFronzo on why preservation of beta cell is key to diabetes prevention. I think this is more and more knowledge on this topic really has to be thing. And of course, we have Dr. Arvind Gupta. I saw him in the morning today. This very nice article published in API, which was beta cell preservation in type 2 diabetes, where they talk about the various strategies we can use to preserve the beta cell. These are some of the strategies: early intensive glycemic treatment, early initiation of insulin therapy, perhaps using of certain agents which have ability to preserve the beta cell, like your metformin or DPP4 inhibitors and so on. So again, one very important message, this is an area of debate. I don't want to get into the debate of this, but a lot of times, there has always been a suspicion that sulfonylureas perhaps hasten the process of beta cell dysfunction, right? Or perhaps lead to more permanent issues, right? Whereas other drugs do not. And this is a very old study, old sort of meta-analysis, where they looked at this article and they found that actually glyburide, led to, over a period of time, these patients on glyburide or sulfonylureas had poor beta cell reserve compared to those patients who were on metformin or rosiglitazone for that matter, right? And then we all have seen this short-term intensive insulin therapy. It has become less popular now, but you had, I remember reading articles of the senior Dr. Sahai on this, a very interesting area of short-term intensive insulin therapy. A patient comes to you, young patient, you start them on insulin, basal bolus insulin, and after a few weeks, the insulin requirement goes away, the patient then goes into remission and then maintains remission for a period of time. So what I'm trying to tell you is that all these are examples of beta cell dysfunction which are reversible, right? I think we need to recognize this important entity and perhaps help our patient in that way. So to summarize, and some important take-home message, first important message for all of us is that beta cell impairment, right, is the key to pathogenesis of type 2 diabetes. Please understand this. There are a lot of tech people I saw, I met a lot of them today. They're working on, exercise and lifestyle and all that. But you have to remember that there is a difference between a pre-diabetic patient and a diabetic patient. A pre-diabetic patient is insulin resistant. A diabetic patient, type 2 diabetes patient, is insulin resistant and having beta cell dysfunction. And this is very important, right? And this is where doctors continue to be important, right? The second important message is that insulin secretion is equal to, it's a function of beta cell mass and beta cell function, right? Of these, which is more important is an area of active debate, but as of now, we would really like to believe that it's a beta cell function which is more important. Perhaps that is why it is more in terms, remission is more likely. And current thinking is more towards beta cell mass function than mass. Preservation of beta cell should be very important, right? It's a key important thing in pathogenesis of preventing or progression of pre-diabetes to diabetes, and also key in preventing the progression of diabetes in patients with pre-existing diabetes, right? So these are the take-home messages, right? We have this app, just for anybody who's interested in this topic. It's called Notes in Endocrinology app, right? So, we made some very good notes. It's a freely available app, right? And we made a, interesting app recently called the Centurion Insulin app. It's 100 years since insulin use. And this app is intended for doctors to really, see which patients are the right candidates for initiating insulin in type 2 diabetes patient, right? So it's again freely available. You can search on either your Android or your Google Play Store for Centurion insulin app. It's freely available, and you can try putting some patients here. You'll see some good results, right? So thank you for a patient listening, and thank you once again to Diabetes India. Thank you.
Thank you, Dr. It was really a basic physiology in-depth scientific learning session. Thank you so much. This is what we accept from you. Thank you.
Thank you so much. Thank you so much.
We'll move on to our next speaker, Dr. Vinod Mittal sir. Vinod Mittal sir, senior consultant diabetologist and head the Center of the Diabetes Metabolic Disease in Delhi. He is advisor and the past chairman of RSSDI Delhi chapter, fellow American College of Physicians, RSSDI Diabetes India and ICP, master class in diabetes management from RCP UK, many honors and awards such as a National Award of Excellence in Diabetes Care and Dr. Sarita Bajaj Oralson in 2019. He is regularly invited as a speaker, principal investigator in several research project trials, national and international as well, and several publications in peer-reviewed journal and chapter in various books as well. Over to you, sir.
Very good evening, everyone. I convey my thanks to the organizers for inviting me to this esteemed annual conference, and thanks, Chairperson, for those kind words. I would be speaking basically on, it's a hot topic today. It's gliptin, gliflozin synergy. Almost every pharma company is now coming with a combination of DPP4 and Sglt2 inhibitor. So it's a kind of an ideal marriage, or ideal couple, we can say, DPP4 with Sglt2 inhibitor. We all know diabetes is a progressive disease, and there it is not only hypoglycemia which matters, but overall its other holistic approach has to be there. So blood pressure, lipids, and then weight management also is important. Now, other important point is now the approach is changing from glucocentric to basically protection or organ specific approach. And their heart and kidney, basically 2/3 of diabetic patients die of cardiovascular mortality, and now cardiovascular mortality is coming down because of good interventions. So kidney problem are going up, and both are going hand in hand. So one point which you all have to understand is diabetic patients, if they have a CVD, you must investigate the patient for CKD, and if patient is having diabetic patient CKD or DKD, investigate the patient for CVD. So both go hand in hand, and generally one is missed. Now other important point is that South Asian phenotype is very typical. We are thin fat Indians, and there is increased insulin resistance in all of us, especially if you have central obesity and beta cell dysfunction we have just discussed by the last speaker. And there is a genetic predisposition. Almost a decade or two Indians are having a diabetes prior to Caucasians. And then obviously lifestyle modification is important. So sedentary lifestyle and other inactivity is all other reasons. What are the unmet needs in diabetes? There is a recent study, in DAB study, and one more study which has shown only 30% of type 2 diabetic patients in India achieve A1C less than 7%. So this is an important point. Why 70% we are failing despite of so many anti-diabetic agents? Other is hypoglycemia. Even one single episode of hypoglycemia in a type 2 diabetic patient makes patient, the patient loses confidence, and patient generally they stop medication. That is why insulin is generally is the culprit, and patient generally avoids. One is pain and other is hypoglycemia. Then weight gain. Already we have 70% of diabetic patients who are having obesity. So, and there are certain agents like pioglitazone, sulfonylureas, and insulin, they also increase weight. So we have to see to these points and then adverse effects of the anti-diabetic agents, and then last but not least the cost. Cost, convenience and compliance. If an anti-diabetic agent is to be given twice or thrice, patient will avoid. There would be poor compliance and adherence. So all these points have to be taken into consideration when we write any anti-diabetic agent. So basically, our aims and objectives are, yes, definitely we have to bring down A1C to prevent complications, especially microvascular complications. For macrovascular, hypertension as well as dyslipidemia, obesity and other factors also have to be, controlled. Now, as I mentioned, the approach has changed from glucocentric to, a glucovascular metabolic, all three. So we have to get down A1C, no doubt. But at the same time, we have to avoid vascular complications and also correct metabolic abnormalities. So basically, there comes the role of, agents which have a side cardio-renoprotective effects and metabolic benefits. So there, Sglt2 inhibitors, GLP-1, DPP-4 are, the agents which are helpful. And obviously, we have to have an early and aggressive approach. We generally say early, it is never early. Even the day of diagnosis of diabetes, it is already late. Patient, the process started around 15 to 20 years prior. Action should have been taken around 20 years before the diagnosis. So it is never early. But still, when you diagnose, at least within 3 to 6 months, A1C should be brought down to less than 7%. Maximum is 6 months, and then it should remain less than 6 months, whole of life of the patient. Now, this is the study, we can see here, like we can see in this study, HbA1c clinically diagnosed, it was 9.1 plus minus 2.3, very high. We come across such patients every day. And then diagnosed during screening, 8.3. So overall, average A1C of Indian adult diabetic population is 8.6, which is very high. And we are talking of bringing it to less than 7%. So generally, we treat to fail. There is a stepwise approach, one agent, 2 to 3 years, it is continued, and second, third, fourth. So basically we are treating to fail. And when we fail, then we add another agent. We never, say from, within 3 to 6 months, once it is controlled, the whole of life of the patient, it should remain less than 7%. Okay, so, we lose so many years, you can see. Insulin, almost 9 to 10 years delay is there in the initiation. And what to talk of, GLP-1 and other medications. And it has been very clearly shown in various studies that 1% of A1C reduction brings down fatal and non-fatal MI by 14%, heart failure 16%, death from diabetes, like that is all-cause mortality 21%, and then microvascular complication 34%, even amputation and other by 43%. So just 1%. Average is 8.6. Even if we bring 8.6 to 7.6 per average, the Indian population, there can be so much benefit. Now, other important point is, it has again been seen that Indian patients, Southeast Asian, including Indian diabetic patients, the DPP-4 enzyme levels are high. So we need to, that is why DPP-4 inhibitors have been found to be more effective in Southeast Asians compared to Caucasians. So that's one point. So that makes DPP-4 inhibitors as a good choice, and other is even Sglt2 inhibitors. So it is more of Sglt2 inhibitors, to a lesser extent DPP-4. Both are more effective in Asian patients. So that makes these two molecules to be used very early. Now, if we see gliflozins, that is Sglt2 inhibitors, basically effect is on kidney. And once there is increased excretion of glucose in the urine, there is normalization of blood glucose, that improves indirectly beta cell sensitivity. And there is also, basically when there is an increased glucagon level, gliflozins, they decrease, early morning glucagon, but that is being compensated by gliptins. So don't bother about this small increase in glucagon which happens in the morning and which is only for first few weeks. It doesn't continue for a long time. And then ultimately, there's loss of weight, systolic blood pressure, decreased uric acid, and obviously normalization of glucose. And gliptins, again there is a dual pancreatic. Gliptins or GLP-1 are the only agents which have effect on suppression of glucagon, no other agent. That is why even the late stage of diabetes, they are effective. So once we combine these two, it becomes a kind of an ideal marriage, and we can address so many pathophysiological defects. So now the things have changed from prior to ominous octet. We all know that. I won't be going into detail, but important point is once we combine Sglt2 inhibitors with DPP4 inhibitor, then almost 7 of 8 pathophysiological defects are being addressed, except the neurotransmitter, which again there are some studies where has been shown that DPP4 inhibitors have some small improvement in even neurotransmitter. So that is, like even if we exclude that, 7 of 8 pathophysiological defects are being addressed once we combine Sglt2 inhibitors with DPP4 inhibitors. Now this is again important that metformin sulfonylurea is the most commonly prescribed combination, and it is quite powerful and good efficacy. Once we give metformin and DPP4, yes, it is again quite powerful, less than maybe a sulfonylurea metformin, but low risk of hypoglycemia. So that's an added advantage. Once we combine all three, then we are achieving even a cardio-renal benefit, weight reduction, and systolic blood pressure reduction. So many advantages you can understand. Okay. So it is always good, and now even ADA 2022 guidelines also mention that patients, irrespective of baseline A1C, irrespective, it is not patients who are uncontrolled. Even if baseline A1C is 6.5 and a patient is having CVD, high risk, or CVD established disease, or risk for heart failure or diabetic kidney disease, give either GLP-1 or Sglt2 irrespective of A1C. You can reduce other agents because of their cardio-renal protective effects. Now, model of insulin resistance, if we see the HOMA assessment, model, there one thing is there, like as insulin resistance goes up, the beta cell function declines. So overall, higher the HOMA IR, lower is the HOMA beta function. So what we need to do is we have to decrease HOMA IR by some means, by reduction of weight. Sglt2 inhibitor is doing that. That will indirectly improve HOMA beta, so that is beta cell function would definitely improve. So overall, this is another important thing. Sglt2 inhibitors have been shown to decrease insulin resistance. We can see here an example with empagliflozin, and then beta cell function also improves with DPP4 inhibitors. So when we combine both, there is a reduction in insulin resistance and there's improvement in beta cell function, both the things. Yeah, so basically there is a complementary efficacy also. When both are given together, definitely efficacy will be much higher. And although when A1C is more than 8.5, the baseline, Sglt2 inhibitors perform better than DPP4. If it is less than 8.5, then DPP4 inhibitors perform better. But when it is higher, obviously then we start with both the agents along with metformin. So despite of high efficacy, now sulfonylureas, we keep on increasing dose. We see a prescription with 4 milligram glimepiride morning, evening. It is not required. We are just increasing the side effect hypoglycemia. Efficacy is not increasing. So 4 milligram onward, there is no increase in efficacy of sulfonylurea. We are just increasing the chances of hypoglycemia. But here when we are adding 2 molecules, there is no added increased hypoglycemic risk. Then other important point is Sglt2 inhibitors, they have an increased risk of genitourinary mycotic infection generally, and there is, the trials have shown that there is a reduction in GTIs with Sglt2 inhibitors if they are combined with DPP4 inhibitors. Probably the mycotic, the fungus which is causing this GTI, they are using DPP4 enzyme for their multiplication. And when we're giving DPP4 inhibitors, by inhibition of DPP4 enzyme, there is less multiplication. So there is less incidence of GTI when we're combining DPP4 with Sglt2 inhibitor. So overall, if we see, there is a better efficacy, more reduction, robust reduction, less polyuria and less infection, and same hypoglycemia. Now, there are some studies which is again very important. Indians central obesity and there's a less adiponectin. This is also has been seen, and here a study was done, and where it was effect on adipocytokines was observed, and we can see here that DPP4 inhibitors and Sglt2 inhibitors, they improve adiponectin levels, and there's reduction in retinal binding protein 4, fatty acid binding 4, and visfatin, which are inflammatory cytokines. So those are indirect effect, so kind of pleiotropic effect besides glucose lowering. Now we have many studies with both Sglt2 inhibitors, so I won't be going into detail, but overall Sglt2 inhibitors have been found to reduce hospitalization due to heart failure, cardiovascular mortality, all-cause mortality. And similarly, we have studies with DPP4 inhibitors, and DPP4 inhibitors are also found to be cardiovascular safe, except saxagliptin, which resulted in increased hospitalization due to heart failure. That's it. Otherwise, yes, vildagliptin and teneligliptin, we don't have any outcome study. So that point has to be kept in mind when we write these molecules. And as far as a combination of these two are concerned, we already have some combinations available. We have EMPA and LINA, we have DAPA and SEXA, and we have Remo-Vilda. But again, with Remo and vildagliptin, we don't have any CVOT trial. So that point, no evidence as of today. So this is only, and now since dapagliflozin is also generic, and times to come, even sitagliptin is going to be generic after July, so there would be more and more such molecules. The only message I would say that cost is important, but never compromise with quality, in a way that all generics are not same, one point. Then you must see the PK/PD studies whenever a company comes, PK/PD profile of that generic molecule compared to innovator. So that's an important point, like we should not compromise on quality. So overall benefits of combining these two are that one is renal safety. Yes, DPP4 inhibitors, they reduce albuminuria. Cardiovascular safety, ease of use, very less side effects. Sglt2 inhibitors, cardio-renoprotective and metabolic. Reduction in systolic blood pressure, reduction in weight, and of that 70% weight loss is fat, and then decrease uric acid. So these are important, additional pleiotropic effects which sometimes become important. Even guidelines today, whether it is ADA, whether it is AACE, EAC, any guidelines you go, I think, for last so many years we've been talking, and I hear also maybe more than 10 speakers must have talked that Sglt2 inhibitor, GLP-1, GLP-1, the only problem is very costly. We have seen in the, I think the first speaker talked, 2.7% only, are, and of those 2.7 also, within 3 to 6 months, there's a lot of attrition rate. They stop taking. Very few patients continue to take GLP-1 analog. So that is why in lieu of GLP-1 analog, we give DPP4 inhibitor. So that way Sglt2 and DPP4 become an ideal choice. So overall, this is my last but one slide. Overall, when we combine DPP4 and Sglt2 inhibitors, what we get is metabolic control, reduction in A1C of more than 1.8%, then other pleiotropic benefits, weight loss, decreased uric acid, blood pressure, cardioprotective effect, significant 3-point MACE, we have seen that, cardiovascular death, all cause and hospitalization due to heart failure, and then renoprotective. We already have DAPA, CKD, credence, and now in next month, ADA, even EMPA kidney, EMPA renal data also would be released. The top line results are already out. So basically, and that is even in non-diabetic patients. DAPA, CKD, EMPA kidney, non-diabetic also, the benefits are there. So overall, the takeaway messages are very clear that when we are, there is a clear-cut synergy between gliptin and gliflozin, and there is a robust A1C reduction, clear-cut, no added hypoglycemia, then weight loss, and most of it is fat, decreased systolic blood pressure, uric acid and cardio-renoprotection. Less genitourinary infection when you combining both, and overall, if we are having generics and of good quality compared to innovator, then obviously the cost, convenience if they're available in one tablet, and obviously they'll make more better compliance and adherence. So with this I conclude my talk and I convey my thanks to all of you.
Thank you very much, sir, for the wonderful presentation. I think we have a question for you, sir.
The combination of Sglt2 DPP4 inhibitor is very good. When we avoid sulfonylurea using alpha glucosidase inhibitor, DPP4, Sglt2 inhibitor plus insulin, we can avoid weight gain and many chances of hypoglycemia. So my preference is alpha glucosidase inhibitors, SGLT2 inhibitor, DPP4 plus biguanide. What is your opinion upon this?
So you're talking 3 molecules, AGIs with DPP4 with
Accepting
SGLT2?
It's alpha glucosidase, biguanide. If you can manage with these 4, why not you sacrifice sulfonylurea?
First of all, any textbook on diabetology doesn't mention giving 4 medications before starting insulin. So it's generally 2 or 3 agents in there, some maximal, more than 50% of their maximum dose. And if A1C is more than 8 or 8.5%, this is the time to start insulin. That's one. So 4 drugs are not recommended, although yes, people are still prescribing. Now coming to acarbose like AGIs with metformin, they both cause gastrointestinal side effects. It will be added. Patients and in India, say if you're giving acarbose, it has to be given twice a day, sometimes even thrice a day, and even voglibose. So giving a medicine 3 times a day will make it, less compliant. Patient will not continue to take it. While DPP4 SGLT2 only once a day. Is that okay? And metformin AGIs is not a good combination. Not a good combination.
Metformin, SGLT, DPP4 plus insulin.
Yes, insulin if required later on. Yes, so metformin, SGLT2, DPP4, insulin is a good combination. No doubt. Yes.
Leaving alone sulfonylurea.
Yes, definitely. Sulfonylureas are to be discontinued when you start insulin, especially prandial insulin. When you starting basal, you can continue sulfonylurea, but when you starting prandial, you must stop sulfonylurea.
I don't think we have any more questions. Thank you very much, sir, for the wonderful presentation, and thank you everyone for being here till this part of the day. See you all on the other side of the break at the dinner, and tomorrow morning for much more better science to be learned. Thank you.